SSM observes the World Genetic Counseling Awareness Day, we need to acknowledge the role of genetics in today's counseling, which is absolutely pivotal. And with advancements in genetics, we have a wide number of genes which are amenable, and therefore we are amenable for more and more genetic-based diseases. But to be very frank, for a non-geneticist, genetics is evaporative. And therefore, it definitely helps to hear them again and again so that these concepts get reinforced the number of times you hear them. For the simple reason, we have two well-renowned moderators, Reema Kumar Bhatt and Dipanjana Datta, who's going to moderate a panel because we believe panel is a better way of learning and reinforcing things, which will be followed by a rapid fire. So over to you, Dr. Reema and Dr. Dipanjana.
Good evening, everyone. And if you could share the slides, please. So I think it's really fascinating to have so many clinical geneticists under one roof. I mean, the amount of knowledge that we're going to take home today is going to be fantastic because they are a rare breed, as I call them, with so much of so much of brains on their head, and it's very difficult to decipher these reports. So I think uh, we are in for a lot of academic feast and a lot of inputs, a lot of clarification of doubts. So let me welcome me and Dr. Dipanjana will be moderating this session. Let me welcome our esteemed panelists for today. So, well, Dr. Ashok Khurana has been the torchlight, as you all know, behind all these academic sessions. He wants us all to get better and better each day. So it is his vision to get everybody together on this genetic counseling day. Dr. Ratnapuri needs no introduction. She's been the powerhouse and the lighthouse of genetics in the country, simplifying things for us. Dr. Sita Ramamurthy is of course, she's been doing great work in Foxy as the chairperson of the Fetal subcommittee. Dr. Katharwal is the consultant clinical lead geneticist with LifeCell International. Dr. Vandana Bansal, again, is a very dynamic fetal medicine specialist from Mumbai and doing some great work. Dr. Vamshi Krishna is the technical director of genomics and clinical cytogenomics of the largest path lab of the country. And Mr. Shekhar Deb is the healthcare leader of genetic diagnostics and clinical genomic advocacy. We welcome you, our esteemed panelists, and we're looking for a very resounding kind of successful panel for today. So we understand that the role of genetic counseling in fetal medicine is extremely important, emphasizing how early and precise genetic guidance impacts diagnosis, our decision making, family support through real world clinical cases. And almost all of us don't understand genetics completely. And that's where the role of genetic counseling becomes extremely important.
So just to emphasize by data that what we have right now. So while I was searching for what genetic counseling means in fetal medicine. So this paper came in where they have actually plotted up a diagram which is saying that how the literature search, the number of literature in fetal medicine and genetics has increased. This is just a PubMed snapshot. You can see in 2000 and you can see in 2020. And I'm very sure by the time we are at 2025, it has increased more. And if you see, it's pivotal because with pregnancy comes a lot of associated factors, the fetus having number of anomalies, as a result of which genetics sits in the center, because many of them, 80% of them might have a genetic etiology. If we look at what genetic counseling means, today being the Genetic Counseling Awareness Day, that the geneticist would actually look at all the existing reports, the clinical reports. They will look at whatever details have been done till now. They will take a 3-generation family history. They will also help the patients to understand what etiology they are going through, what are the manifestation, what are the possibilities of these manifestations, and if needed, they will suggest further genetic testing. These genetic testings are not simple, so interpretation of these testings are also important, and correlation of what we are looking in genetic as a report and the fetal phenotype or itself the family manifestations are very important. And we just don't stop there. We also would extend to the psychological support and help them make an informed decision. So that would be the what happens in a genetic counseling session or when it happens. But India is a bit unique because we have a lot of other issues that we also deal with while we are doing that. It's not a straight cut counseling because we have to take care of the social status, the religious status, and also as well the economic status. So it has to be best for the patient. It's not what is actually best. It might be optimum if we look at it, but it has to be something that is best for the patients, and they need to have the autonomy to choose it rather than what is what we feel is right. So that is what is the crux of genetics and genetic counseling. And with that, I will ask Rima ma'am to please go ahead with the first case.
Right. So we have this patient, Mrs. M. She has a strong family history of suspected X-linked muscular dystrophy with her own sibling brothers being affected, and who succumbed at the age of 28 and 24 years, respectively. The brothers had frequent falls. They had difficulty to climb stairs from around 2 years of age, which gradually progressed to non-ambulation. So as you can see there, we have the affected child in red, marked with the arrow. So now,
So just I would add, this is my mistake. So the Mr. M, Mrs. M is the one which is marked with a bold arrow, and you can see that this is the nephew who has actually come, and the nephew is nephew is also affected, and this is the family history. Sorry, ma'am.
yeah, no problem. So we move on to the first question, which goes on to Dr. Can we have the next slide? So, Sita ma'am, we want to ask you if we have to understand this pedigree well. Mrs. M comes to the clinic asking for prenatal testing as she already knows that her nephew has genetic condition. What would a fetal medicine expert do? Would you advise this patient on your own, or which features in the pedigree point towards the X-linked recessive inheritance?
Yeah, thank you for the question, Rima, and thank you for this opportunity to be part of this wonderful webinar on Genetic Counseling Awareness Day. So, 5 years back, maybe I would have said just refer to a geneticist or genetic counselor. But over the years, we are learning that genetics is part of our fetal medicine as well. And we need to know the basic pedigree chart. So it's not that difficult to have the basics, but of course, we will need guidance from our experts, from our genetic counselors and geneticists. So here, as we can see that this, the lady is a carrier, and she has had affected males which have succumbed. So typically the males have been affected and the females are carriers, and say they're obligate carriers. So it's an X-linked recessive, as we would call it, where all the females are carriers, they're asymptomatic, and the males are affected, and they can transmit to 50% of the children or females who would be carriers, and 50% would be affected. So at least this basic we would be able to understand, but further obviously we'll need more detailing of what was the affection and how bad was it and other details.
Right. Thank you, Sita ma'am. So what is really, really important in genetic disorders is to understand the pedigree. You need to draw the pedigree, the 3-generation pedigree, and then come to a diagnosis. That's extremely important. So,
My
Dr.
next,
Yeah,
yes.
next question, Dipanjana.
Yeah, my next question would be to Dr. Katirwel sir. So, how would you assess a carrier risk? Because this woman, if we look at the pedigree, we know that it's an X-linked disorder, and she probably has a 50% chance of being a carrier itself. So, sir, how will you assess? What exactly would you be looking at the pedigree, and how will you counsel? Sir, hello.
Dr. Kathirwal, you'll have to unmute yourself.
Please unmute yourself.
Okay. So anybody can take on this question. So, Dr. Ratna ma'am, can you just guide us through what's happening? How do you assess the carrier state of Mrs. M given the family history?
Okay. So if you see the pedigree, Mrs. M does not have any child as yet, but her sister has a son with DMD. And if you go back here, that makes it easier. Thank you. And you can see that Mrs. M's brother also had DMD. So for the boy whose mother is marked at 42 years, she is what we call an obligate carrier because her brothers have DMD and her son has DMD. And so her X chromosome would be having the DMD gene with the variant, one of them. However, Mrs. M, and she's marked with the big arrow, we don't know. So if her mother is a carrier, that means there are two X chromosomes, one with the gene mutation and one without the gene mutation in the DMD gene. And so the one without can come, she's not the carrier. And if the one with the mutation comes, then she is a carrier. So there's a 50% chance that she's a carrier and a 50% chance that she's not a carrier. So that's how you assess her risk. And then does this question also have testing? No, it was just what is the...
We have the testing question just a bit later.
Yeah. So this is how you assess the carrier risk. If there is no significant family history of DMD, then she's at the population risk of being a carrier for DMD.
Right.
Thank you, ma'am.
Thank you so much, ma'am. So that history taking and pedigree charting is extremely important. So, ma'am, coming to you, would you recommend testing asymptomatic female relatives in this family? Why or why not?
Well, I would not, because I know that she has a 50% chance that she's not a carrier and a 50% chance that she's a carrier. And therefore, if I do a test directly on her, remember it's a test, it's a laboratory test, and there can be many errors in a laboratory test. So if it comes positive, I'm happy. Well, I've identified her to be a carrier. But if it comes negative, there is always a little worry that because of the nature of laboratory testing, whether it's a hemoglobin CBC or it's a genetic test, okay, have I missed her carrier status? Because DMD gene is a very big gene. It has 79 parts. And either it could be a change in any of the parts, or it could be a part that's missing or in excess. And so therefore you always start by confirming what is the mutation in an affected individual. Once we have that mutation, then only we check that specific mutation in the lady. So a targeted testing is more definitive than an untargeted testing. And so the first line of testing in this case is what we call an MLPA. Now, why do I say that? We have to go back to understand what is the genetic mechanism of this disease. We know that 80% occur because of, one of the 1 to 5 to 3, any amount of parts of those 79 parts that are missing, or they are duplicated. So the way to pick this up now, there were different ways 15 years ago. I won't talk about that. But now we use a technology that is called MLPA that looks for deletions and duplications in this gene. If that is negative, then I will go on to next generation sequencing. Whether I do a clinical exome or a whole exome, that's my choice. Uh, to look for any point changes in any of those 79 exons of the gene. Why don't I sequence? Why don't I Sanger sequence? Why am I doing an NGS for one gene? Because we always learn that NGS is done when we want to look for many genes together. Because I told you it's a big gene, it has 79 parts, and therefore it's very expensive to Sanger sequence it. And so therefore, a easier and a cheaper technology is next generation because it's high throughput. Yeah, so that's her mutation.
Yes, so we exactly did what ma'am said. We actually first tested the nephew, and we got that there was six deletions in six exons from exon 45 to 50. And with that information, the Mrs. M was also tested. And in this case, we did an MLPA because we knew that in MLPA we could get that. So we tested with an MLPA, and MLPA in Mrs. M was negative. So I'll move on to the question. So this question is to Professor Khurana, sir. So many a times patients, this particular patient said, all right, I've heard about non-invasive testing and my neighbor did a non-invasive testing. So you are saying that I am negative, but why can't I do an NIPT in detecting if there are any kind of mutations in the DMDs? So sir, what would your counseling be?
Well, hello to everyone, and welcome to this absolutely fascinating get together of geneticists to get our messages across on this wonderful day of being aware of what genetic counselors are all about. NIPT, of course, means only one thing to the patient, and that is you get all the answers for all the questions with one test without the uterus being poked. The first thing we have to tell them is that no, NIPT is used for different genetic disorders, and some of them are in an evolutionary state. Some where it is very accurate are wonderful, such as trisomy 21, with appropriate counseling and clinical evaluation. But for DMD, yes, there is an NIPT available. In the best of laboratories, it has an 86% sensitivity, which is completely inadequate for a disease that can be so debilitating, and therefore it would not be a sensible choice because we would end up missing 1/5 of the patients who would probably be having it. The other thing is that we still don't know whether the false positives have been adequately analyzed or not. Therefore, NIPT is an inappropriate test as of today for detecting DMD mutations.
Thank you, sir. So I think we're very clear that if we want to look for DMD, it's the index case that needs to be evaluated. And it is only then that can we take this forward. And NIPT is not the answer. So our next question to Dr. Vanzana Bansal is, what would you discuss if this was a preconception counseling for the couple? Or if Mrs. M conceives, how do you frame the risk communication? How do you address maternal guilt and anxiety in a carrier mother for X-linked disorders?
Thank you, Rima, for the question. So we have been discussing it is an X-linked disorder. So we've evaluated the mother and she is not a carrier at the moment in this report. So one is we would do all this evaluation, see whether she is a carrier or not. And since she is not a carrier, the risk of fetus having a disorder is very less. But it is still not zero. There are chances of gonadal mosaicism even in DMD. Maybe Dr. Ratna can add on to this if you think that should with no carrier, if the female is not a carrier, do we still do a prenatal testing? I will leave it to Dr. Ratna, but for my question, I will speak to her. If by chance she's a carrier also, then also 50% only will have a problem, and other among the males 50% and among the females 50% will be carriers. So maternal guilt, I would not let them get into the guilt of having this problem because it is something which is there in her blood, and that we have got prenatal testings which are available. And in case we are able to find a problem, then we have options of termination early. And so I would not let her get into a guilt of doing this. And for this, I will get my counselors also to talk to them. And here also, I will have my genetic counselors also who can help them not to get into this guilt that they are carriers and they are going to give it to their children. But prenatal testing, whether I'll do or not, Dr. Ratna, there is, when I read through all this, there are a lot of gonadal mosaicism which are associated with DMD, which I actually did not know earlier. But then, do I not test or do I test them without the
So,
carrier?
if Mrs. M is not a carrier, remember we have tested her only for the familial mutation. It's very important to understand that.
Hmm.
There is a mutation in the family. We've only tested the carrier status for that mutation because that's what's indicated. She remains at the baseline risk of having a child with DMD because there are 30% of children who can have a de novo or a new mutation that is not inherited from the mother. So in genetics, you can never say that, yes, you are 100%, I guarantee that everything will be okay. So the way to put it across so that the families don't get worried is that you are at the baseline risk and you're not at an increased risk because of the disease in the family.
Yes.
The concept of gonadal mosaicism came in when you had a lady who's not a carrier but had two children with DMD. So, how did that happen? That happened because of two cell lines in the gonads, okay, but not in the blood because you've tested the blood and it's not there. You can never confirm or test for gonadal mosaicism. But if a lady has had one child with DMD, even if she's not a carrier, you will always do prenatal diagnosis for her in the next pregnancy because there's a very high rate of gonadal mosaicism for DMD.
Thank you so much, ma'am, for so beautifully answering that question. And thank you, Vandana, ma'am, also for answering the counseling part of the question. So we move on to another, sort of question which we face in the clinic. The couple says that, so say this particular couple, there is the mother is a carrier, and we did a prenatal testing, and they say that, all right, but we do not want females who are carriers. The couple does not want a female, a child who is a carrier, because they are saying my daughters will face the same thing. And so this question again goes to Professor Khurana, sir, that in such a case, how would you handle these questions? Like how to counsel and what to say?
So I have several options here. The option that I would have used 30 years ago is to ask them to shut up and throw them out of the clinic. And that is the best thing really to tell people like this, because they have no business to think like this ever in their life. And I would tell them in so many words. But over the years, I've learned that you start with pulling them onto your side and then make them feel ashamed of how they think. And that really is the point. And we would tell them that, look, it's wonderful, but tomorrow if you discover that your wife has a problem and yet has had these normal children, then what would you do? Would you replace her? And this is the way you get them onto your side. And it's purely hypothetical, but they would not know the science behind it, but then they would start feeling stupid from the beginning. Then you gradually pull them over to your side and say that, look, this is like saying that every woman is replaceable, and you do understand that no woman is replaceable. And therefore, they need a lot of counseling. If they still don't understand, I would say maybe I should refer you to a psychiatrist, because that would be the final, don't come to me, don't trouble me with these things. In 2025, you have no business to think like this, is what is at the back of my mind. But I try to put it gently and get them over to my side and try and make them see sense, because hopefully they will then carry the right message. These are the kind of index people who, when they go back into society, and if I'm able to convince them, we'll be able to convince the rest of society. And this is why we have to have them on our side.
Absolutely, sir. So that's why sometimes we take so much time in counseling such patients, even with the normal reports. So my next question would be to Shekhar, and this is a question which is, I would say, thought-provoking also, that what should be the lab reporting guidelines for X-linked disorders? We understand there's a PCPNDT where we are not supposed to disclose sex, but if we are doing a prenatal testing for X-linked disorders, how should a lab handle reporting, especially where we know that this can also be a method of determining sex?
Thank you, Dipanjana. Well, we can't be as when Dr. Khurana is like the Don and Godfather, he can do that. For us, the lab has to follow the strict PCP-NDT protocol where both direct and indirect disclosure of fetal sex, we have to be very careful. So as a lab, we stick to reporting only the genotype. That's what we always stick to. And yeah, we don't mention any carrier status on the report. So we stay away from reporting carrier status and we just stick to that what's present or not present. That's where we don't use word like hemizygous, homozygous, nothing. We just stick to the genotype reporting.
Right. In that way, only the professionals can understand what it is, and
Correct.
we don't disclose the carrier status. And anybody wants to add anything to that, like the panel? Anyone in the panel wants to add anything to that?
Yes, you see, the law is very clear. The law clearly states that when you have an X-linked disorder, you're allowed to report everything about the X-linked disorder. The tragedy is that the people who execute the law, the so-called bureaucracy, refuses to understand or are actually corrupt. And it is this moral corruption that stops you and me from actually acting within the law. We are made to feel guilty about what is going on when actually the law clearly says that you can mention every single detail. This is actually the essence of modern genetics. Unfortunately, because there is our life, our career, our profession, and the whole, the essence of an industrial organization at stake, or a lab or a company at stake, we have to be very careful of the corruption in our bureaucracy. But the fact is that it exists. In Delhi, for instance, we have in South Delhi, in Southwest Delhi, my district, we have an extremely understanding PCP and DT department, and everything is just fantastic because we're on on the same page. But this does not apply to most parts of the country. So you have to be very aware of your local environment before you sink your feet into this and get stuck.
Dr. Dipanjana, can I ask Dr. Ashok Khurana one question?
Sure.
X-linked disorders, if it comes at around 18, 19 weeks to you, do you only see the sex and tell them not to do a prenatal testing?
Never out of perspective. And the
If there
fact
an
is,
if the same patient has a
yeah,
carrier status, then
yeah,
she's come late to us and
that's right.
is a female fetus.
And you see, the fact then is clearly that because she's been evaluated, she does not need genetic testing. There is no doubt about that. And in that situation, the risk of genetic testing are not justified. And if she was in any other nation where we didn't have a PCP and DT Act, she would not have genetic testing done. And we've been following this actually in our district for many, many years.
So
And
telling the patient would be, you
no,
don't
telling the patient is not correct, but we say, look, I'm making out an ultrasound report for you, and I will communicate these results to your obstetrician and to the fetal medicine person you're concerned with, and then we can work it out. You see, because I come from a generation where sex determination was legal. It became illegal only after 1996, and we'd been practicing for a decade and a half before that. So I get a lot of referrals even in this day and age because people are not familiar with it. But because my generation was familiar, we still know how to do it. And we often face this with the lab. And even when we undergo sometimes like a placental biopsy or a CVS at 14 weeks, you can generally become quite familiar with what the sex is. This is the actual truth. And no, you can't hide science behind curtains, which is not the actual truth. So, of course, there is a debate to this and a philosophy to this. But the fact remains that are we really justified in invasive testing when we know that it is of no use from a scientific point of view?
Right.
Thanks, sir.
Thank you, sir. So we come to our second case. I think there's been a lot of intense discussion. We move to another controversy. Now we had this 25-year-old trichorionic triamniotic IVF conception. She was reduced to singleton somewhere outside. She came to us for the first time at 28 weeks, 2 days. Her NTN anomaly was reported as normal, and she was referred in view of bilateral hydronephrosis on growth scan. Now, ultrasound at 28 weeks, 2 days demonstrated fetal growth restriction, but the Leica was normal and the Dopplers were normal, and there was persistently distended urinary bladder seen. Can we move to the next slide? So my question to Dr. Vandana Bansal is at 28 weeks, we get a patient whose NT anomaly has been normal with normal Leica, normal Dopplers, but with early onset severe growth restriction, which is less than the first centile. Would you want to evaluate further and how?
And so Rima, can you go back to the previous pictures?
Yeah.
So first is it was a triplet to start with, and so we would not have had any biochemical screening done. It would have only been an NT and an anomaly scan which was done, and they were reduced to fetuses. So again, no biochemical screening was done. So probably the NT and anomaly at that time was normal. So now at 28 weeks, if you look at the centiles, the head is also on the lower centile. The head circumference is also first centile. AC is also first centile. Femur is okay, and the weight is less than the first centile. So it is a early onset FGR first centile, but there is good amount of flicker around. There is actually looks more than normal also. And in addition, I see a distended bladder with this kidney also looking cystic and some amount of hydronephrosis, and the pelvic test is not very severe for this kind of a distended bladder. So putting it in perspective, one, it was a FGR with a normal Doppler. My antennas will go up because I am more worried about the fetus rather than this being a placental disease, because the uterines and umbilicals are normal. Then why does the baby have a small size? Additionally, we have these markers. We have got pelvic tests and a distended bladder. So any early onset FGR, especially if there is Leica, which is good, and the Dopplers are normal, then I am thinking that there could be a fetal etiology to this, and I would go ahead and do an amniocentesis for this patient. But what do I send in the amniocentesis? I am more thinking of some ciliopathy or some kind of a single gene disorder, or so I would do a QF PCR as you've written here, but my first option would be to do a whole exome for this patient.
Right. So can we have the next slide? So the dilemma here is whether we go for, so we will put that question. So this patient was, she had IGF2 gene, she was heterozygous Silver Russell syndrome, that was autosomal dominant, likely pathogenic, reported by the lab. So my next question is that to Dr. Kartival, what genetic test should you consider first? Should it be chromosomal microarray? Should it be a targeted gene panel because you're suspecting some renal abnormality with FGR, or a whole exome sequencing? So how would you want to evaluate this patient?
Okay, ma'am. So we are apologies for the technical glitch. So we are now dealing with early onset symmetric FGR with normal Doppler and normal Ecker. So as ma'am, on top of that, we also have bilateral hydronephrosis with distended bladder. So it is not a typical placental FGR. So raising the antenna for possible genetic etiology. So obviously, we have to go with microarray first because as it is both in studies from meta-analysis, it has shown both in isolated FGR as well as FGR with soft markers and other system involvement. There is considerable risk for chromosomal abnormalities first. So microarray would be best choice as it is endorsed by other societies also. So coming back to this approach of using exome for CNV. So as we know, the add-on utility of getting copy number variation in exome, so it all depends on the sensitivity of this method, and we get like there are also some discrepancies in most of the in validating the CNVs. So CNV which is directed to exome has to be always validated to with an orthogonal method, and in time constraint setting in such as prenatal setting, going with a standalone exome would be like controversial in some settings. So my approach here would be I will never go for a targeted gene panel. I would go for an qPCR with microarray and exome, adding exome for normal microarray cord. Yeah, in some meta-analysis they have shown fetal with isolated or complicated IUGR with normal CMA and doing exome has picked up some incremental yield, some rare diagnosis have been have been picked up. So it can be used to complement each other, microarray exome, but a standalone exome would be detrimental. So there are issues of for orthogonal validations of if CNV identified. Also, the major concerns of raising VES and standalone exome versus trio exome also is debatable. So in that case, my approach, so in this particular case, considering the severity of phenotype and multi-system involvement, if a microarray exome can also be added along with microarray, but a standalone exome, I'm still not I won't recommend a standalone exome. I can
Right.
also get advice from and opinion from other experts here.
Right, Dr. Kartival. So I want to ask Ratna ma'am. Ratna ma'am, there's always constraint for time, constraint of money, and patient doesn't want to spend so much. So what's the rationale? Should we go for simultaneous testing, CMA and whole exome? Should we do whole exome with copy number variations? So we're all confused at all points of time.
Rima, I think the first thing we have to note before we get carried away by all these tests is the gestation. This lady was at 28 weeks. By the time you do her scan and you do her testing, it never happens that you've counseled her today and you say, okay, let me take out the fluid and, run all these tests on it. So I have a little bit of an issue there. We had a bladder that was distended, and I presume that on the scan you had excluded that it was a posterior urethral valve because that is the most common thing. Probably it wasn't thick or whatever. But I feel at the start of it, I mean, how did you say it wasn't a PUV?
So, ma'am, it wasn't PUV because there wasn't the hydronephrosis that we expected was not there. So, what happened was it was a transient bladder distended. Probably the tone was poor. So, when we rescanned her after 2 weeks, the bladder wasn't as distended as it should be.
Okay.
Main clinical finding that we are, so that's how we get carried away with ultrasound. So, the main clinical finding is that it was FGR. FGR is what we were.
Agreed.
Ma'am,
Now,
PU valves would have had like a less rather than poly.
no,
We would
I don't
see
agree there
sometime
because if it's a chromosomal, I have seen a couple of cases, and that's how I've learned it the hard way, that where you have anything that's out of the ordinary, then you think I need to do a genetic test because I need to explain that finding. The standalone is you have a PUV, you should have less LICA. Agreed. Okay.
And dilated urethra.
Yeah. So now the second thing is we have our main phenotype, like you say, fetal growth restriction. Now you go back and see what is the genetics of fetal growth restriction. What is the yield of, so you've said it's maternal, fetal, placental. We've ruled out maternal. I guess you've ruled out maternal. You've ruled out placental. So we are left with fetal. In the fetal, what are the various causes? Have you taken your history for all the, teratogens, whatever, all those reasons? Have you looked at infections? What is the yield of chromosomal disorders? And then what is the yield of exome sequencing? I think that is the way to go. And we know, as you got in this case, you may have had Silver-Russell-Silver syndrome or one of the other methylation disorders, which are not picked up by exome sequencing. They are picked up by MSMLP. So rather than just do a test, what I try to tell everybody is for every anomaly, the yield is different. And it's very important to go by the yield and do the appropriate test. And there is actually, especially at that gestation, I would have preferred to do a trio exome. At least that's how I do it. I don't do solo prenatal exomes unless I'm looking for something like cystic fibrosis in echogenic bowel. Or, I know it's a rhabdomyoma and I want to just look for a specific gene. Because it's very difficult to answer. It's very difficult for the lab. And that's why we get so many VUSs. I mean, that's how I would look at it. And that's what I've learned over the years.
True, ma'am. So what we want to highlight here is that it's not just picking up something on a test. It's also how you interpret and how you convey it to the patient and what is the end result. But this baby, ma'am, was born for the convenience of the audience, was born, and there's no neck holding. There is the severely delayed milestones even at the age of about 11 months. So this baby was baby is not doing well. So the
Which is
question is
okay,
that,
but
yeah.
you were
So,
too many tests where you may not get a genetic basis. It
right,
could be unidentified. We are highlighting a case which has got a positive genetic report with a not a good outcome. Okay, but routinely, let me tell you, Silver Russell has a very good outcome. They are intellectually normal, they're just short children. You give them growth hormone and they are good.
right.
So,
So
are we
here,
dealing with something else?
yeah. So see, so
Madam,
what is really important here is that you have to involve, we have to involve the clinical geneticists. The decisions can't be made on our own.
at 28 weeks, Madam, Dr. Ratna, trioxome is correct because all these reports will take 4 weeks to come.
Time.
And
So, would
patients
you really
want
want to do
answers to
it?
this.
Would you really want to do it
Yes.
at 28 weeks? That's
True.
what I'm
Yeah.
trying
Yes,
to
ma'am.
debate.
That's what I'm also
Hmm?
saying. Okay,
Yeah.
28 weeks, if they come to us and they say we want answers, then trio definitely yes, because we will get some kind of VOUS, or maybe even if I get an autosomal dominant pathogenic, I don't know what the parents are. So trio is correct to do, ma'am, but it should be done if the patient has come to you and you are picking up something, ma'am. You
I
can't
don't think so. I don't think so. You have to talk to the patient. You have to talk to the patient. You have to tell the patient what the timelines are. We are nobody to order that you have to do this test. It doesn't work like that.
I
We
think
have
it
so
is
many.
always the choice of the patients. Like we
Yes.
give them options,
True.
and that is what we are, and we can give them the consequences of the options. But apart from that, I don't think we are in a position to take any decision. It's absolutely
and
the couple's decision.
and
True.
then if it comes out, then these late terminations, it's a boon also, and it is a very
Traumatic,
difficult thing to
very
manage.
Pain,
traumatic for
Very
the
yeah.
traumatic for
families.
parents
Yeah.
as well as for
Yeah.
us also.
Yeah, so that's what we want to take on. Our next question for Dr. Khurana is that, sir, the late terminations, the ethical considerations. So if we had something more severe at 28 weeks, which is probably non-lethal, what about the termination options under the current regulations? There are a lot of confusion still in the minds of people, and how much prognostic certainty is required to ethically discuss late termination with unclear genetics, like in this case.
True. So this is one of our biggest problems, but what the law has fortunately done, and this is why we worked on the law for 11 years before we managed it, was to make sure that every option was in the hands of the medical fraternity, so that we could then guide them with a medical background rather than all the other backgrounds that used to creep in when we used to have late terminations. But one thing is certain, that the biggest problem that we ever have is time to be spent on counseling. And this is the whole reason why this whole concept of the genetic counselor has come along. The practicing obstetrician very often has neither the skills nor the knowledge, because they've been concentrating on practical skills for delivering and things like that. The radiologist makes a phenotype and has not enough adequate grounding or time to sit and counsel. And the fetal medicine person with an obstetrics background will again be stuck with time. So we need to make sure that we involve someone who has the time and the inclination and a clinical basis as well. So in fact, what we're hoping to do is to introduce somewhere along the line that every genetic counselor should do an internship with a medical organization before they finally receive a certification of being a particular type. There are several names that are going. People call them clinical genetic counselors, or clinical geneticists, etc., etc. Really speaking, we don't need to define that. We need to define people who have time to sit with the patient. And the time to sit with the patient is to then figure out what are the patient's expectations, the fact that they have a doomed diagnosis, undoubtedly, but also that we cannot deny destiny beyond a certain point. So that kind of a philosophy cannot come with clinical counseling or with a clinical appointment. We must have that background. The other thing is that all our patients seem to think that genetics is a magic box and will give us everything. And we have to let them know that genetics is not always just a complete magic box. There could be non-genetic causes of several things. And the fact that no diagnosis can ever be complete until an individual has grown up. And then, of course, we give the patient the cafeteria approach so they can choose what they want. Because if we go to a medical board, there is no doubt that if you have a prognostic uncertainty, then there is no way we're going to get permission for a late termination. Late terminations, we know, are possible even during labor, technically speaking, all the way up to 41 weeks and until the first cry. We can manage that, but not after the fetus has been expelled. So therefore, we have to be very careful about giving them support for a late termination for non-lethal abnormalities. It's not within the law, really. Non-lethal, but with a very poor prognosis. Who is to decide in this situation what is really the very poor prognosis? So that kind of a philosophical discussion has to then involve a genetic counselor with adequate time and a clinical background.
I just have one thing, that if we actually read that amendment to the PCPNDT for these late termination, they've kind of like listed some things.
Yes.
Where all these things don't come in clearly. However, we are, still hosting those boards and then deciding, okay, intellectual disability, but they actually don't come in those list of disorders.
No. And
so sometimes I wonder, like, what are we doing?
Yes. You see, the thing was that we can't produce a new generation that is medically perfect. We must admit that to ourselves. And the patient should also be aware of that we cannot guarantee them perfect babies or designer babies. It is not possible. And the expectations of the patients have to be trimmed right from the beginning. So right from pre-conceptional counseling, we have to give them these possibilities, however unrosy they might seem. It might put off a few people, but then they will, with time, become mature and then accept to have babies. But we, even though the indicative, the indications that are given in the appendix to the law, we have a last sentence. They say that this is not an exhaustive list and is only a representative list. But we have to keep that perspective on life. We can't have just this minor perspective that, okay, non-genetics, okay, it should be all right next time. We can't do that either. It's not so cut and dried. Or that this is genetics and it is a terrible thing. No, because genetic diseases are not necessarily terrible. So A, as professionals, we have to get that mindset, and B, everyone involved in counseling has to have that mindset. And most importantly, every counselor has to have time.
Now, if we have, sir, Dr. Khurana, sir, we have this report of Russell. Should we now, will the medical board allow termination? And how can we tell the parents after this that, okay, you continue the pregnancy, it may not have so much of morbidity? So either we do the test or we don't do the test. If we do the test, we can't tell them now we don't do anything.
Yes.
No, but that was the question I also had for madam, that
Yes.
Dr. Ratna madam had said that, with Salva Russell, some of them do well. Not all of them are affected. So
Yeah.
how do you sort of counsel these it's not mandatory, it's of course the patient's choice, but the baby might be normal intellectually after birth. And so there is no point in telling them that they need termination. And secondly, also another question I had is that if this lady had presented at 20 weeks with severe early onset, maybe my focus on doing genetic would be much more than at 26 weeks, because we don't have that much time. And also that if it is just isolated early onset growth restriction without any other obvious anomalies, would we harp on genetic testing? That's another thing.
Yeah. So that's why I said, whatever the anomaly is, whether it's fetal growth restriction, whether it's anything, whatever, first you have to go back and see what is the yield of different tests. We have to review literature. I mean, we do it all the time. I don't order a test without going and reviewing because things are changing so fast. So you'll see what is the yield of a chromosomal, what is the yield of single gene, what do we want to ask, what is our question, and we order the test accordingly. The second thing is that the Silver-Russell outcomes depends upon the mechanism of the mutation. So whenever you get something in the report, you have to go back and see. But sometimes that there are reports which are reported as pathogenic, but they are just carriers of an autosomal recessive disorder. It is not disease causing. Sometimes there is one gene that can cause both dominant and recessive disorders, and there the mechanisms are different. So you have to see that mutation, missense, frame shift. There's so many types of mutations, and then decide, then go back to literature and see. You can't decide that will this sort of a mutation cause a dominant disorder or a recessive disorder? So is this person affected, or is this person just a carrier of the autosomal recessive form of that disease? And therefore, just seeing pathogenic on the report is not equal to a bad outcome, like Dr. Khurana said, and equal to termination of pregnancy. Because here we are dealing with unborn fetuses, and we have to make sure we are not terminating normal fetuses. Now, for this Russell Silver, coming back to that, Sita, there is it's an imprinting disorder. So specific kind of variants are very good. They do so well. But a different kind of gene variant like this may not have good.
And we must really understand that this is not something that the average practitioner can handle. I mean, most of us don't even know that it's chromosome 7 and chromosome 11, and that this is an imprinting disorder, and what is an imprinting disorder, and what is some of my literature tells me 35% will have a hypomethylation in 11p, and the others say 67%. Now that is really the difference between minor and almost everyone. So we have to be very, very careful on how we counsel in these situations. And we must admit to ourselves that as everyday medical professionals, we can't have this kind of knowledge. We have to involve very specific genetics, and we have to involve very specific counseling.
Rima, you're mute.
Yeah. So thank you for those wonderful inputs, ma'am and sir. And the purpose of presenting this case was to understand that we have to be very, very careful when we ask for a test. So, Dr. Vamshi, how can fetal medicine teams collaborate with genetic counselors to ensure timely testing, turnaround time for actionable cases where we can take actions? What are the red flags that should trigger urgent multidisciplinary discussion between the lab, the genetics, and the fetal medicine teams?
Thank you so much for the question. I think a rapid the turnaround time from the sample being collected, which means that I have a differential diagnosis, and this is what I need to clarify whether my patient has so and so, has to start with a pre-test counseling. So counseling is the main pillar of a multidisciplinary team, and that counseling has to start with a pre-test counseling. Fine. So these were the symptoms. These are the differential diagnoses, and these are the different platforms that we're going to use in a genetic laboratory to try and confirm, or to try and say that to rule out a specific condition or a specific mutation or a variation in a gene or a number of genes. That has to be really very, very well followed up after the report is out with a post-test counseling. So a pre-test counseling and a post-test counseling, you have a spectrum from where you are in connect with the patient, with the patient's management team. And so you understand the longitudinal, understanding the longitudinal time frame of when you've ordered the test, when you've got that specific result, what it means on the lab aspect, what it means for you to have different options that your clinician is going to talk to you about, and how does that each and every option affect you as an individual and affect you affect your family and your extended family members. So that turnaround time is something which should be at the heart of counseling. Either that counseling comes in from the clinician aspect who has time, or in a very busy setup, obviously the genetic counselors take up that that really important aspect of making the patient understand the entire condition as to why they visited a hospital in the first place. All the red flags, anything which requires an immediate attention, if it's an acute leukemia, if it is something which is a trisomy 21, if it is at the late ends of gestation where you have to take a decision of the MTP and so on and so forth, anything which has an urgent medical condition to be looked at, those are the red flags that I would want to look as to quickly have a call with the patient's treating physician and say that this is what it is and how do you have to manage. Let's do it out. Let's do it with this is what is the counseling report, the pre-test and the post-test, and I think that would be the best way or the ideal way to go about it.
Right. Thank you, Dr. Vamshi. So it's a lot of pre-test and a lot of post-test counseling. It's just not asking for a test. So we would request Dr. Khurana and Dr. Ratnapuri to give us some take-home reflective, what to reflect on, that how do we ensure that genetic counseling is not an afterthought, but an integrated part of fetal anomaly evaluation?
Well, I have one sentence. We have the Society of Fetal Medicine, and we're trying our best. But with 3 million, no, how much is it? 3 crore pregnancies, 3 crore pregnancies. We obviously have a long way to go. And the rest I leave to Dr. Ratnapuri.
I know, I was thinking of that when Sita was speaking. It was like a desperation. How do we figure it out? And I think we just have to increase our trained manpower. We do have a lot of genetic counselors, but I think we just need to insist on a little better training and not just, segregate in the very parents. And if it's not there, then you terminate. If it's there, it's not disease causing. And so I think we really have to enhance our training qualities, which is what you were talking about. That's the only way we can do it. It is becoming so intense that I think it's becoming a little difficult for one person to do it all. And so I do feel that in fetal medicine, where the need of genetics is so intense, and the implications are so important. It doesn't matter if I say something to a family where they have a child already. I can call them up tomorrow and say, well, I've reviewed something else. Please come back and let me correct it. Can't do that for an unborn baby. And so I think we just have to increase our trained manpower.
So
Thank you, ma'am. Yeah.
Thank you so much, ma'am, for that very insightful, feedback. And thank you, sir, and all the panelists for the case two. It has been what we wanted from out of this panel. So we present the case three, and in the case three, this is a case where there was no consanguinity. This is a woman who has one male child and one female child, all well. There is no any family history is not present. And if we move on, then with the scans, the NT-NB scan was not even done. The biochemical screening was also not done. She shows up at anomaly scan with a dilated bilateral lateral ventricle measuring 16 millimeter. And in the follow-up scan, the bilateral moderate ventriculomegaly was noted with 11 millimeter and 10.5 millimeter, which is basically borderline, but complex cardiac anomaly with DORV and TOF was found. Now, amniocentesis was sent for, again, QFPCR, WES with CNV. And my question first to Dr. Sita ma'am would be that when NT-NB is not done and these anomalies have come late, like how would you counsel? What are the clinical red flags? And when would you refer for a genetic fetal evaluation? And what exactly would you counsel in these cases?
In these women, when actually the biochemical screening has not been done, there is always, that risk that they have not been screened for at least the common aneuploidies. And now at what gestation are we looking at? Because she said at follow-up, there was this ventriculomegaly, right? So what gestation are we now?
This is close to 20 weeks.
20 weeks. So at 20 weeks, yeah, So whenever we find a CNS abnormality or cardiac abnormality, usually though cardiac, if it is typical TG or something, it's may not be related. But with CNS abnormalities, we really worried there could be a syndromic association. We look for other things. So especially if these come up late, I would strongly go in for a genetic evaluation, because especially if the previous biochemical screening has not been done. And now with the termination, as we've discussed, being 24 weeks, we have time to, counsel and do these tests. If she's at 20 weeks, I would strongly go in for all the genetic tests that's needed. And typically, if it's only ventriculomegaly, you have two anomalies, two organs affected here, the heart and, the brain as well. So there is a strong indication that there is something, syndromic association here, and we will go in for genetic testing. So that's how I would counsel them.
So my next question would be to Dr. Karthik Bell, sir. So what with the findings like ventriculomegaly and the complex cardiac anomaly, what would be your approach to genetic testing? So now that we have established that we would do a genetic testing, now what would be your approach to this genetic testing?
Thank you, ma'am. As mentioned here, the usage of qPCR, CMM, whole exome. So obviously qPCR would be mandatory. So it's gonna screen your, it's gonna be a rapid screen for aneuploidy, and as well as MCC, and giving the report in 24-48 hours would help in major decision making for significant aneuploidies. But microarray is non-negotiable, as it is an major cardiac defect. And we also have on top of this, we also have ventriculomegaly. So adding these together, definitely the underlying events would be most likely an copy number variation. So adding CMA would be very essential in this deorbit of with the ventriculomegaly presentation. Whole exome, yeah, it can help in some cases, though there's as some multi-system involvement. Rarely it can also be monogenic, and few cohorts are shown despite normal microarray. Adding whole exome in cardiac anomalies can pick up some rare mutations. So this going for tired approach at a later gestation is little worrisome, as time is very essential. A parallel approach with all these three tests would be very essential. And with this particular setting of Diorite with ventriculomegaly, going with a simultaneous testing would be much better approach compared to a tied approach.
So,
I'd just like to add here that even if the previous biochemical screening was done and if that was normal, such an anomaly would warrant more genetic testing. So, I wouldn't just rely on that and take it like everything's okay. Yeah.
So thank you, ma'am. But my next question would be to Professor Khurana, sir, that how would you communicate the limitation of prenatal imaging versus genomic testing to the couple in such complex cases? Like, as Ratna ma'am had said, it may or may not have a genetic yield. So how, and the patient might also ask that, you are seeing two different things in two different scans. So how do you counsel this?
So actually, the problem is that a lot of patients, when they when they hear from each other, they think that genetics is the answer to all problems, and they must be made aware of the fact that it is not. The question is that, first of all, we as professionals should be aware that genetics is not the question or the cause for all conditions. That you can have multifactorial, you can have other factors, and you can have completely non-genetic causes. Once we ourselves are convinced of that, we must understand that counseling cannot be done as a single sentence. It has to be an interactive session. It has to have the time, and it has to be repetitive. We presume the same degree of intelligence on the part of our patients and the same degree of comprehension when sometimes they don't even understand the language that we are speaking, both technically as well as actually. So I might be speaking in English and their level of English would be different, or they might not even understand things at all. Now, for instance, how is the patient supposed to know that genetics and heredity and chromosomal are different? And some people presume that genetics is genes and chromosomes are chromosomes because they think they're very well informed. Now, these are the limitations of human thinking that all our patients must be made aware of. And therefore, patients should also be told clearly that, look, someone is going to spend time on you, and it has to be either done in a general hospital where people's taxes are used for it, or you have to come in for a consultation where you have to pay for it and you may require multiple consultations. They must realize that they have to have health insurance, and pregnancies must have health insurance as point number one. B, we should be aware of the limitations. And C, in the final analysis, you cannot sugarcoat everything about life. We have to let them know that we are not God, we're not promising anything. And we as professionals have to stop playing God. We are humans, we are professionals, and that's where the buck stops. And I tell them this always.
That's a very beautiful message, and also, that we shouldn't also overexert that genetics can do everything. And this is something that, needs to go out there, that genetics is not a magic box. In fact, it can, indicate a Pandora's box. So in this case, where because WES was done as expected, we got two heterozygous variants in ZNF, one in ZNF292 gene, which was classified as uncertain significance, and the other one was in AFF3 gene, which was also heterozygous and classified as uncertain significance. Now, it was associated with, one was associated with intellectual disability, one was associated with kinship syndrome, which was not really, both of them were not really matching the phenotype of the child. Like if we do a genotype phenotype, these were not really very significant genes to work with. So my question here would go to Ratnapuri ma'am, where I would say, like, how do you explain the significance of these variants to the patient, especially if there was no pre-test counseling done for them? And labs reporting unrelated genes with clinical, like with or without clinical correlation, should there be some kind of guidelines or restraint in reporting these kinds of variants? And how do you draw the line between uncertainty and inaction? And what about the medical legal things that lab might face? So too many things when we are reporting these cases.
Ma'am, you have to unmute yourself.
Okay. I think for a start, we first have to understand that we cannot identify anything and everything in genetics. Even if we have a disorder that is 100% genetics, the diagnostic yield of all tests combined together for a cohort of phenotypes is not more than 40 to 50%. We struggle with undiagnosed patients. So that is our first thing. When you have to give a background, okay? And so when you have this background that the body is complex, science is advancing, we only understand one teeny weeny bit of it, it's fine if we miss something. But I think what we have to keep repeating to ourselves is it's very, very incorrect. And I think we are at fault if we discontinue normal fetuses. So that sort of a report, which you just showed us, Dipanjana, is something which should not have been reported in a prenatal because there are variants of uncertain significance. I do know that when I analyze postnatal children with genetic disorders or adults with genetic disorders, I do correlate a phenotype with the WOOS. And I do think back at that time that if this came in a prenatal report, I would have said, don't report it. But it stands like that. There are international guidelines and very soon guidelines coming up in combination of the Society for Indian Academy of Medical Genetics and the Society for Fetal Medicine on prenatal testing for fetuses. Okay, they are ready. Now we just have to circulate them to the Society of Fetal Medicine. It tells us when to test, how to test, what needs to be reported. We only report a WOOS if there's already one likely pathogenic variant for an autosomal recessive disorder and is consistent with the phenotype. You can never have a NDD phenotype in pregnancy because this causes a lot of problems. And so I think understanding we can't give all answers, knowing that we should not be reporting WOOS, and we've got so many representatives here from all our great companies who actually are doing such a good job because we are where we are with genetics because of them. They have made tests available. But like you said, it's very important to have restraint in reporting, and for us as doctors to understand it's fine to get a report where it's a normal report. We don't have to push them into reporting things. So I think that's the way we go forward. Also, understanding that in postnatal life, when we have a phenotype, I have gone back to the same prenatal data and taken out a variant which is disease causing, which could not have been identified in prenatal life because we did not have that phenotype. So the data is always looked at with a phenotype. It's not just looked at, the terabytes of data that we get. So I think really that's the background and the perspective that I wanted to give.
Thank you so much, ma'am, because I think I had a conversation with you before on this, and this is something that we absolutely need to understand that here, number one, counseling is very important. Number two, the lab should have some restraint in reporting, and unrelated phenotypes, except the ones which are given as those 79 genes, should not be actually reported because there are many things that can be missed. And
I think the expectations of the doctors also have to be.
Yeah.
I think
Yeah.
it's a two-way relationship. I don't blame the labs only. It's a two-way relationship.
Absolutely, absolutely. So we move on to the next question with that insight. And my question to Shekhar would be, what is your view on reanalysis policy of VOUSs, and should prenatal samples be reevaluated after delivery or termination if there is a cause?
Yeah, I'll come back to what Ratna ma'am said. Reanalysis can be done any given point of time, but entire analysis for genetics depends on the phenotype. I mean, the better phenotype we have, the better reporting a company can do. Obviously, as ma'am said, in pediatric setting, it's much easier, much better for us, for a lab also to do reanalysis. When it's terminated, I mean, product of conception, fetal autopsy, even a baby gram can help us do reanalysis of the vows. But we need good phenotype, or if there's an additional phenotype that coming to the lab, it's only then a reanalysis matters. As a lab, I think most of the lab in India, globally, we have our own policies. Every 6 months, 8 months, we look at the data, we do reclassification of variants, and then we inform the doctor or the clinician if there's an upgradation or we have downgraded the variant. But yes, I mean, if we have a reanalysis can be triggered at any given point of time, provided we have some additional phenotype for us to look at if that vows can be reclassified or not.
Yeah, thank you so much. And also maybe sometimes couples want to do a trio, combined analysis, which sometimes can increase the yield in some cases. Yes. Okay. Thank you. So we move on to our next question with Dr. Vams. So now say if the same patient undergoes different kind of genetic testing, how does the lab ensure that there is no variant redundancy or reporting conflict? And how do the labs decide that when to actually if there is a cascade testing of parents and siblings, especially for VOUSs or carrier findings, is there anything the lab has or any policies the lab might have? So what would be, how would the lab deal with these kind of things?
Thank you. Wonderful questions. The first one is for different types of genetic tests. Obviously, there are different platforms, there are different expertise. And so the different expertise would try and match the pheno, and then will try and give out their reports. If it's from different labs, different companies, different setups, we surely see that there is a chance that I feel that the phenotype matches partially with a specific mutation. The same thing would be seen by the other lab, says no, this is a deletion duplication on the CMA. I've got this, and this possibly fits into this specific patients. So if it's from different labs, so I'm sorry, I think we would have a reporting conflict. But eventually, when it comes back to the treating physician, and that is where we kind of look at it, and then we see the entire picture together. Go back to the respective labs, or maybe go back to the same lab with different expertise and different reporting people, and then have a combined sort of look at the different tests. That's how we will be able to do it, and I don't think there's any other way, especially if patients benefit in mind, we can do that. For the second question, I think it's a variant of uncertain significance. Variants of uncertain significance basically mean that they are significant, but the significance is uncertain. And why is it uncertain? Because we do not know in our population. We kind of look at different databases which are there everywhere around the world, and that phenotype has not been expressed, or that variant has not been reported and is not into our databases, has not been published. So that's a lot of gap which is there. In India, our obviously our genome is different, and then again in different ethnicities, different genomes would come in. So a characterization of a variant of uncertain significance, I think Mr. Shakid has really very well put it. We have to have a policy, a periodic 3 months, 6 months, before pregnancy and possibly at prenatal and then post pregnancy. Some policy a lab should have, so that we understand that a VUS can become a likely pathogenic or a pathogenic based on whether we ask for an extended family testing or a cascade testing, and based on which we would be able to possibly try and recategorize the variant according to the ACMG. Ma'am, if you can, if you want to add something more to it, I would be, I think it's a wonderful question which everyone would ask to each other, at least in the labs, every single day for VUSs.
Yeah. So for reanalysis, I think that there are standard guidelines world over that if there is a change in phenotype, you order a reanalysis. I don't think it's humanly possible for any lab anywhere in the world to just keep reanalyzing the data, and it will not have a yield unless we provide another phenotype or unless there is a new gene identified. That is the time when it gets clicked off in your databases, and then you inform the physician. So I think our perspective for reanalysis also has to be around that. Why are we doing something? It's not easy task looking at data, and so therefore it's always said, if you have a new phenotype from that what you have reported, ask for a reanalysis.
Right. Thank you, ma'am. So I think, do we need any change in the system level, sir and ma'am, to improve timelines, clarity in such cases, or we are happy with what our labs are providing us with?
Should I just say that in one line?
Yes, ma'am, please.
We need to work together. And it's like all specialities are now mapping out, it is a multidisciplinary team. And I think we form our team, and if we work together, we become stronger. What I know today, I didn't know last year. I am becoming stronger every day because we work together. And I think that should be the flag line for our society.
Yes, ma'am.
Absolutely true. Until just a few years ago, it was regarded as unethical to even discuss or name a particular laboratory. Everyone thought it's terribly wrong. And we've broken through that sort of glass ceiling at the Society of Fetal Medicine to realize that, excuse me, that's Delhi's pollution, to realize that truly speaking, we cannot disconnect laboratory personnel from ourselves because we are the same team. And there's no question of who's bigger, who's smaller, who's MBBS, who's not, and things like that. It's very straightforward. We're all here for the patient. The patient needs the lab. The patient needs us. There is nothing unethical in making sure what a lab is giving us. There is no harm in discussing what pricing is, because the patients ought to know and all of us ought to know. And therefore, we have to move together. So I do hope that other societies also keep up this trend. So if we get support from pediatrics about the same thing, then we can carry on with exactly what we're doing now, which is a very, very close association with the labs, even so much so that I could pick up the phone and tick somebody off to say that, look, the demographics from your lab are not coming out right. And please make sure that you mention this in your report, etc., etc.
Thank you so much. Thank you so much to Sir, ma'am, and our wonderful panelists for those inputs. I think it was a very vibrant session. We have one very rapid session awaiting, and we have another team of some fabulous geneticists again in this team. So, and this would be rapid questions. So we will post the question, and our panelist would give us the exact answer. So can we have the list of panelists? Yeah.
Yeah, so the concept which we wanted to bring about over here is that can all the panelists actually switch on their cameras, and so we can just have it KBC style. So yes, so we just want I'll just put the next slide.
Yeah, so
thank
we'll lock the answers that will be given by our panelists. So
Yes.
let us welcome Dr. Shagun Agarwal. She's professor and head of medical genetics at NIMS and very active in genetics in the country. Dr. Sunita Bajarnia, again, vice chairperson, senior consultant at Gangaram Hospital. Dr. Ashwin Dalal, head diagnostic division center for DNA fingerprinting and diagnostics. Dr. Seema Thakur, senior consultant, genetic and fetal medicine, and very active in AOGD. Dr. Prakash Gambhir, who's the chief medical geneticist of LifeCell International and actively helping everybody with finding solutions to cases. So we come to our first case, which goes to Dr. Sunita. During counseling for increased NT at 12 weeks, the NT is 3.5 with normal CMA. What is the next step discussion which is most appropriate? So we've given you 4 choices. You can choose the best choice and you can negate all as well.
So I can give 2 answers?
You can, yes.
Well, so let's look at the choices. The choice is reassure that NT less than 4 always resolves. No, that is not true. Recommend exome sequencing, rasopathy and ciliopathy. Not a very straightforward answer, but I guess this appears to be the most plausible. Then C, offer only fetal echocardiography at 20 weeks. So the word only doesn't sit well in this answer, and so probably not. And then the last is consider maternal tort screening only. Again, it's not that specific. So I think the best answer is type is B, which is we have to go further with our genetic testing. Whether it is exome sequencing or rasopathy or ciliopathy panel, that needs to be discussed. And as we have had a very wonderful panel, it has to be a conversation, a counseling session, which will lead to these answers. Thank you so much.
Thank you, Dr. Sunita. Yes, indeed. So it's not just one answer, it's a lot of counseling that goes.
Yeah, so our next question we have to our panelist, Dr. Shagun Agarwal ma'am. So here the couple presents with a bad obstetric outcomes. There are 2 fetuses. One fetus had shown in the anomaly scan cerebral hypoplasia. CMA was normal. At that time they did a WES, but that was also normal. In their second pregnancy, again, the fetus had congenital abnormalities. The fetal autopsy revealed dysmorphic features, joint contractures, talipus, and bilateral polycystic kidney. Now, this time because WES was normal, they did a WGS, like whole genome sequencing in the fetus. And the whole genome sequencing report came to have a homozygous variant in the PNPLAH gene. And this particular mutation was also tested in the previous fetus whose DNA was kept. And that fetus was also harboring this homozygous PNPLAH gene. And if we look at OMIM, we really don't have too much of like genotype phenotype correlation. I would leave it to you with the next question and then come back. So how should we approach counseling for this couple regarding this finding? And I'll move back to the first slide so that it helps you to speak.
So thank you, Deepanjana. So again, I mean, just a disclaimer, I don't think this can be a rapid fire panel because, I mean, counseling and these kind of complex scenarios, we can never take rapid decisions. I mean, there are so many things here. So this case also, for me, I would like to really review the scan of the first baby, the scan of the second baby. I would really like to see because both of them, one thing, have the same variant. So I would like to really look at the phenotype more closely For both the cases, I would like to look at the autopsy findings. I would like to, get in touch with the person who did the autopsy, speak to the pathologist for so many things. And why I'm saying this? Because of course, like here we are seeing, yes, the variant is uncertain, and we are seeing that OMIM phenotype is not fitting. But there are so many things here. I mean, one is that we need to realize that these kind of databases are not like really up to date. So, if today I look at PubMed and tomorrow I look at PubMed, there can be a new paper and which could be just showing that there is an expanded phenotype associated with this particular gene. In fact, today itself, I have looked up PubMed just to see, if there is something else reported. And there are reports of, prenatal onset, not really joint contractures, but cerebral hypoplasia, microcephaly, which is associated with this particular gene, actually. And then in addition, at least one of the case reports, there is a photo of a baby which seems to have arthrogryposis, So I would not immediately disregard this variant. I would like to dig deeper, is my answer at this point of time. So one, I mean, if such a report comes to me, one thing we always recheck that variant again, using our own bioinformatic, pipelines. There are nowadays some easy softwares which are available online for free use. So we always use that to recheck the variant classification as geneticists. That is one. Second, we again mine the literature. We see if there are any recent reports which are not incorporated in the OMIM phenotype, which are expanding the phenotypic presentation associated with that particular gene. And third, I would like, now that this particular gene is known to be associated with this mitochondrial myopathy with lactic acidosis. So, of course, in a fetus, I cannot demonstrate an increased lactate. I cannot demonstrate some of the features like intellectual disability seizures. But I can go back to the pathology slides. I can look back at the muscle tissue, although pathologists say that in fetuses it's difficult to study the muscles. But if available, I would like to see if there is any evidence, in the pathology which is kind of correlating with the mitochondrial myopathy. Now, before completely disregarding this variant, because see, we are seeing that there are two fetuses affected, both of them are sharing variants, the same variant. There is probably some, like the first fetus had cerebral hypoplasia, which is known with this particular gene. The second had some joint contractures and some additional findings, again, somewhat matching. So I not immediately throw it out as my answer. But yes, if we have to choose from these choices, what you have given me here, so I would say that yes, the most appropriate answer at this point of time, given the amount of information we have, is that yes, this variant does gets classified as a variant of uncertain significance. Whatever phenotype is there available on your slide, again, as I said, I would like to mine deeper, but whatever we are being provided here, it's not completely matching with what is given in OMIM database. Again, this is not sufficient yet, but still. So at this stage, just immediately we cannot say that this variant in cause is causative, and we would not want to offer a prenatal testing for this variant. In fact, I would want to keep that patient on repeated ultrasounds and see if any of the phenotypic features come.
Yes.
In case they come, then we could test that fetus, and again, as a prospective thing, we could demonstrate, or we can look for additional phenotypic findings related to this variant if this is again found in a fetus which is having some kind of a phenotypic presentation. So we would like to do further further, I mean, at this point we can't use
Analysis.
this as a standalone kind of the cause and offer prenatal and offer termination if the fetus has this variant, but we have to correlate again with scan. And so at present, yes, with the limited information, B is the answer, perhaps the best answer at present. But again, I mean, we need to kind of do more I would say digging,
Yes.
and we have to keep the family on follow up. We have to kind of till we get an answer, because there would be an answer. And then of course, I mean, we would also with joint contractures again as finding, we also need to remember some other things. Like sometimes, it could be other situations like the mother has myotonic dystrophy and the fetus is now having a large expansion and the fetus is presented with a congenital myotonic dystrophy. Sometimes, rarely, spinal muscular atrophy. A type 0, which is a very rare subtype, may present with joint contractures. So these are conditions which will not come in an exome. So again, they don't explain, of course, all the things here, but just to keep in mind that joint contractures, even if recurrent as an arthrogryposis, does not always give you an answer on an exome because certain conditions you need a different kind of test. So, I
Yeah,
mean,
we actually looked into the SMA also for this couple. This was my case, and I actually also looked into SMA for this. They are normal. So
yeah.
that
That anyway doesn't explain, of course, the complete phenotype. I mean, my gut feeling is that this is probably the causative variant in this condition, but I would like to look at the scans
more
and the
deeper.
autopsy
Yes.
myself. Yeah, yeah, is what.
Thank you so much, ma'am. Rima, ma'am.
Yeah. So this is our next question to Dr. Prakash Gambhir. Consanguineous couples expanded carrier screening reveals both as carriers for the same autosomal recessive condition. Husband has a heterozygous, likely pathogenic variant, and wife has one heterozygous variant of uncertain significance in the same gene. Now, this is how the report looks like for both husband and wife. What should be explained to the couple?
Thank you, Dr. Rima, and thanks for having me here. So I will like to answer this question Kaun Banega Crorepati style. There are 4 choices here. So I'll go from the most negative answer that no counseling is needed. So that is should be thrown out, as Dr. Khurana will say. So every test requires pre and post-test counseling, especially when there are special tests. So counseling is definitely required for this case. It will cause a disease in next generation, and the fetus has both variants. Termination is the inevitable outcome. I'm not sure about this because I have to weigh the vows, in fact, and just do a prenatal diagnosis without explanation limitations. Again, is not a correct thing to do because you're going to make a decision for a fetus which is not yet born, and also you do not know enough about the variants. So the way I will go forward in this case is to look at the vows that is there, and it should be evaluated. And if it is a good vows, before the to call it a good vows, one question I will like to ask the couple is whether there is any previous case affected with the same gene when the phenotype is matching. In that case, then possibly it is possible that this vows, if it is strong, then we have to offer prenatal diagnosis. Also here, this is a consanguineous couple. I expect it with grade 3 consanguinity. We expect the variant to be the same in the couple, but it's not the case here, and it's not very uncommon in our country because it can happen in that way. So we don't always expect the variant to be same in a consanguineous couple, but we have to weigh the vows first and then offer prenatal diagnosis. It's a strong vows if there's a previous case with similar affection with the genotype phenotype match. So that is my answer to you. So the question 8 is my choice. So I will give a weightage to the vows after it has been evaluated, and then offer the diagnosis.
Lock kar diya jaye, I think.
But Sunita ma'am has a hands up.
She's raised
She
her
wants
hand.
to
So
add.
there is, yes.
Sorry if I may just interrupt here. Thank you so much, Dr. Gambhir, sir. I just wanted to inform the audience that this is a metabolic disorder. In case the couple wants to go ahead with the prenatal testing, one should also know that there are some functional tests that are possible in the fetus. So in case the fetus turns out to have both the variant, then some kind of a enzymatic functional testing is possible. Although in this particular case, it is really difficult because there's no enzyme assay that is possible, but some decarboxylation assays and something like that. But there are ways to make this VUS either upgrade to likely pathogenic or downgrade to benign. So we should not leave it. So the answer, of course, is very aptly put, but it remains in the gray zone.
Yeah.
Right.
Wonderful. So
Thank you.
we
So I
lock.
think it's, yeah, so we've locked the first choice. Thank you, Dr. Gambhir.
Can I add one thing, Dr. Rima, to what Sunita ma'am said? No,
Yeah, yes.
just that no. Although here, of course, in this condition, it's not possible. But some other metabolic disorders, like the lysosomal storage disorder, we can also do enzyme assay for the carrier parents, and they can sometimes, I mean, show that enzyme values to be activity to be in the borderline range. Like it won't be as low as an affected baby. It won't be completely normal. It will be low normal. So that also adds to our evidence. Of course, the answer is A, but I'm just saying, there are ways to arrive to evaluate that VOUS. So for metabolic disorder, that's one of the ways. And suppose this was a VOUS in a gene which is associated with a fetal phenotype. So this condition doesn't cause a fetal phenotype, but suppose it is. Then we can also wait, till
Correlate.
16 weeks or something to see if any kind of a morphological abnormality is also kind of pointing towards the same condition, and then use that to help our decision whether we want to do testing. So, I
Right.
mean, so
Right.
many other
Thank
things
you.
we can try together. Yeah.
Thank you, Dr. Shagun. So I think there we will send to the geneticists. We can't handle all of this.
So our
So
next question
yeah.
goes to Dr. Seema Thakur, ma'am. So a couple who age 27, they undergo premarital hemoglobinopathy and they are non-consanguineous, no family history, but both of them come out to have HBE trait. Now, how should you guide this couple? So they are asking if they would need a prenatal diagnosis once when they plan a.
Yeah, so this is a condition where both the couple is E trait. So in this situation, there is 25% risk that there will be E homozygous. So we need to understand that E homozygous will not result in thal major or thal intermedia. So no prenatal will be needed in this situation. So I would like to log the B, that they explain that the two hemoglobin E carriers can have a hemoglobin E in homozygous state, which is usually mild, but of course that doesn't carry here that the beta thalassemia. If there is another one which beta thalassemia, then of course they need the prenatal testing, because this might result in thal intermedia or thal major. So here the couple is E trait, so no.
Wonderful, ma'am. But here I just want to ask, would you sequence would you ask them for a sequencing, or would you ask them for a repeat HPLC, or would you look into the iron? Like, would you look
No,
into anything
we
else
do
for him?
no, we first do the molecular confirmation that whether this is actually hemoglobin E trait, and then only the counseling is based.
Yes, the
So no
reason to
further
ask
repeat.
that sometimes
And of
HPLC
course,
can.
the ethnicity sometimes. Yes, because at the same situation, it might be, D Iran also. So that creates confusion. So it's always important that they should be molecularly confirmed that they are actually hemoglobin E trait. So they need assurance.
Absolutely. Thank you, ma'am. Ma'am, you have to unmute yourself. Ma'am, you are on mute.
I'm so sorry. Yes. So we have a 25-year-old G1 para-0 referred for antenatal screening, male partner who's 27 years old, healthy, no known family history of anemia or hemoglobinopathies. This is the hemoglobin report where you can look at MCV, MCH, RBC count and RDW of both the male and the female partner. The iron studies of the peripheral blood smear are normal. The female partner shows microcytosis and the male partner shows mild microcytosis. So my question is, how do you explain the clinical significance of borderline HbA2 in female and normal HbA2 in the male, especially with microcytosis in both? So Dr. Ashwin Dalal, if you could take on these questions. And what is the threshold for recommending partner testing and prenatal diagnosis in borderline or indeterminate thalassemia carrier cases?
Yeah. So we can't really have a threshold. First of all, as we know, HbA2 may be affected by presence of iron deficiency anemia, especially in the pregnancy. And in such situation, when there is a borderline, we could always opt to do a molecular testing, because that will clearly tell you whether the couple is a carrier or not. Since thalassemia has most of the thalassemia patients in India at least have the common mutations, about 15 mutations account for more than 90% of the cases. So mutation analysis will remove this dilemma of borderline cases. And when in doubt, probably that would be the idea, because these biochemical parameters might get affected because of iron deficiency anemia. And so decision will have to be taken at that time. But a molecular testing is anyway needed if any prenatal is to be ordered. So it's better to go for molecular testing.
So,
Right. Thank you.
thank you, sir. Just my follow-up question here, sir. Sir, in some cases, we are seeing right now that there are a lot of silent alpha thals also when we are looking at such microcytosis when the iron studies are also normal. So, sir, because if we test for just the HBB sequencing, we might miss on alpha thalassemia. So, how should we sort of counsel, or what should be the pointers where we might ask the couple to do a alpha thalassemia screen?
Yeah, so that way there are so many other conditions. So because of microcytosis, maybe you could suspect alpha, and again alpha, the common deletions could be checked by doing a MLPA for carrier status. But as I said, see, there's no end to screening. So how many conditions would you screen, and whether every patient of microcytosis, because most common cause of microcytosis in India will be iron deficiency anemia. So then, but still you could do alpha thalassemia screening by MLPA to look for, because we don't have any particular indicator or a thing on HPLC to tell us that this could be alpha thal. But yeah, always whatever possible we try to do to find if they both are carriers.
Thank you so much, sir. My next question would be to Sunita ma'am, Dr. Sunita Bijaranya ma'am. It's a 25-year-old prima gavita presented at 20 weeks of gestation for a detailed anomaly scan, and they have come up with an isolated echogenic bowel. So there are no other anomalies seen. Torch screening was negative. Maternal serum biochemistry is normal. So what should be the best next step in evaluation and in counseling?
Thank you for the question. So it is a quite common scenario, and I'll just go through all the options. So number A is to reassure that isolated echogenic bowel is always benign and requires no further workup. It is an obviously no. So the option B is recommend parental CFTR carrier testing, discuss possible association with cystic fibrosis or related disorder, and consider fetal testing if both parents are carriers. Well, it seems plausible, but probably not the only option. One could go ahead and do some direct testing in the fetus as well, in case the couple decides to do so. And C answer, advise immediate termination, of course not, and treat empirically, again not an option. So the best possible option out of the four will be B, that yes, it does increase the chances of cystic fibrosis in the baby because of the echogenicity of the bowel, and some form of testing is required, and therefore one could go ahead with the parental testing first, followed by fetus. Or if the couple would like to know in view of positive time, they could go ahead with the amniocentesis for the genetic testing.
Thank you so much, ma'am. Ma'am, here just another point, what to test, because CFTR gene is again a complicated gene.
So CFTA gene is a big gene, and the best method to go ahead with testing it would be a next generation sequencing. Although it may take a little more time, but that's the best option here. the laboratory should be informed in advance that this is what you're looking for, because there are certain mutations that may be deep intronic, and if they do not get this a heads up from the clinician that you are suspecting this, they may just overlook these. So the cystic fibrosis CFTR gene should be totally checked out.
And
Thank
Down,
you so much.
Down syndrome?
Other than cystic fibrosis, of course, chromosomal abnormalities and
Which are the
infection,
first one.
everything is
Yeah,
there. Yes.
yeah.
So
Yeah.
I
And
would in fact,
most common cause is actually bleeding,
Yeah,
So
and some kind of FGR as well, I guess.
yeah,
So there are many reasons for that.
yeah.
and I would also, like to, ask the lab to also look at the Hirschsprung associated variants in Hirschsprung disease associated genes, because the echogenic bowel could be the earliest manifestation of an evolving Hirschsprung disease. Also, now that we are doing invasive testing, so in
Yeah,
fact,
so we have
as
actually decided on invasive testing, all
yes,
of us then.
yes, that we
It's
should
not an
actually.
option in A, B, or C, or
Yes,
D.
I completely agree with Sunita ma'am. Actually, the right because time is of course one factor. Cost is another factor, and of course, echogenic bowel is associated with the. Aneuploid is associated with cystic fibrosis, associated with again rarely, but yeah,
Gambling.
an evolving Hirschsprung disease or other gut malformations, which again could sometimes be due to a genetic condition. So we have to offer an invasive testing. There's no role of doing a parents carrier testing, wasting time, wasting money, then doing invasive testing when we have so many other things also which needs to be checked. So best is to offer them invasive and look for everything.
Yeah,
All these
sometimes
conditions.
simple bowel atresia also, looks
Yeah.
like this only.
Yes,
Yes.
Yeah,
yes,
then after
exactly.
excluding all, and someday I'll find in the ward, I'm going to the ward and I find that the child is admitted. What for? Oh, my child just underwent the surgery for
Yes,
bowel atresia,
exactly.
and that gave me understanding, okay, there is beyond our genetics also. So there are, bowel atresia also, which will result into this echogenic bowel. So we have to look everything, all, thinking
All
laterally,
options.
everything.
Right. Thank you so much. So our next question to Dr. Shagun is this 32-year-old woman underwent non-invasive NIPT at 12 weeks. The report indicates high risk for trisomy 16. Ultrasound at this stage is normal. Now, how do you interpret and communicate this finding to the couple of NIPT?
So first, of course, we always need to tell this fact to the couple that NIPT is a screening test. This is very important because very often couples, after spending the amount of money they spend on NIPT, they assume that it's a very, very big test and that will look for many genetic conditions and it's a very good test. So if it has come positive, means the baby would probably really be affected. So that we have to first baseline, counsel them that this is a screening test. It can be false positive. That is important. So we need, but of course, NIPT, because it's a DNA based test, usually the positive predictive value is pretty high, although it's much higher, of course, for the common aneuploidies and lower for such rarer autosomal aneuploidies like trisomy 16, but it is still much higher than the serum screening. So if we do the serum biochemical screening, it comes positive. The positive predictive value is just 5 to 6%. Whereas when we do NIPT for Down syndrome and all, of course, it's like really high, around somewhere around 90%, 80-90%, depending again on age and other factors. But for even for something like trisomy 18, it will be quite high. So quite high as in somewhere in something like, 25-30% at least. So so now next step now, but of course with trisomy 18, pure trisomy 16 in the fetus, we would expect that by this time the fetus would have miscarried perhaps, or if not miscarried, would have shown some major scan abnormality, but the ultrasound is normal. So is the fetus right now 12 weeks with a normal ultrasound, or
Yes,
is it
12
like,
weeks, 12 weeks
Yes,
with
ma'am. It's
normal
a normal
ultrasound.
ultrasound. Yes, ma'am.
yeah, at 12 weeks, right? So one, of course, there can be findings which could evolve later. So that also is one thing, because we are just at 12 weeks gestation at this time. So now basically what this needs is that we need to do a confirmatory testing to see whether the fetus is really having trisomy 16. So again, one thing, I would not like to do anything at this point of time at 12 weeks. So there are two reasons for this. One is, of course, that NIPT per se is checking the DNA which is coming from apoptosis of the placental trophoblast. So again, if I do a CVS at this point, I'm again sampling the placenta only. So we all know that there is a phenomena called as confined placental mosaicism, whereby the trisomy could be just in the placenta and would not really be there in the fetus. So in that case, your NIPT would show trisomy 16, and if I do a CVS again, it would show trisomy 16. So it would again leave me kind of nowhere in a way, because it is possible that it's just a placental trisomy 16 and the fetus is normal completely. So I would first thing not want to do a CVS, of course. And second, of course, the other thing is that because we are just at 12 weeks, so it's still possible fetus could be having trisomy 16. It's just that key right now the scan is not showing the abnormalities, or like, the fetus could be, this could be ending up in the miscarriage, but has not happened yet. So some trisomy 16 end up in a miscarriage even in the second trimester. So for both these reasons, I would like to wait. I would like to call this couple at 16 weeks. I would like to do an early scan again to look whether any morphological abnormality is there, and provided that, of course, the pregnancy remains viable. And then at that point of time also, let's assume the scan is normal. So now at this point of time, I would like to do an amniocentesis. And then here, the point here, so this is something which I have learned by seeing two recent cases whereby the couple had come with a positive, one was trisomy 9, another was trisomy 22. Both cases, the scan was completely normal, and this was at 18 weeks. Not 18, sorry, 17 weeks for both of them. And actually, in both cases, it did turn out to be a fetal trisomy, but it was a mosaic. One was 20%, one was 30% mosaic. So it was not even CPM. So we think that a NIPT positive for a rare autosomal trisomy, I mean, one reason is, of course, CPM, but the other reason could be that the fetus could be a low mosaic. So this is something which, it's not kind of which I have learned through my own, experience. Last few 6 months, I've had these two cases. So what I would do is I would do an amniocentesis. I would do an array. Array, why do I want to do? Because I want to also keep in mind, sometimes it could be a partial trisomy, and whereby again scan would be normal or there is no miscarriage. So I would like to do an array. I would also like to do a karyotype to make sure that I don't miss a low mosaic. And I would like to also preserve a slide to, in case, there is a doubt of low mosaicism, if I need to do a fish. So this would be a case where I would actually like to do a gamut of test. First, of course, I mean, QFPCR as a routine is done, and a microarray to look at, suppose it's a full trisomy 16 or a high mosaic trisomy 16, it would come in microarray. But in simultaneously also a karyotype for mosaic, and also preserve some slide for a fish if it is a low mosaic. I think Ratna ma'am wants to say something.
Yes, yes.
Ma'am, yes.
But I just want to ask you one thing. You said that you do a karyotype for mosaicism, and if it's there, then do a fish. Why don't you do a fish straight away? Because that
Ma'am,
is a better answer.
yes, ma'am. We can do, ma'am. It's just that, I mean, that also can be, yeah. That's
Yeah.
also possible.
I
We
mean,
could do a fish for
because
16.
so normally what I do is, because you're not looking for 21, so instead of doing if you're doing an amnio, instead of doing the general fish, if you're doing a fish, you just do a fish for the 16 or the 9, because such probes are always there in labs. And
But
therefore,
not always lab. I don't know whether every lab would have a pro for, maybe, I mean, Gangaram would be having,
yeah.
but 16 and
I
9.
do have. We do
Yes,
have
ma'am.
in our lab. And so therefore it also gives a little quick answer to the family.
Yes, ma'am.
And then
Yes.
the array.
Yeah.
I mean, I
So
was just asking, I was not commenting, I was just asking if there is a specific reason that you do in that order. It's just, I think, based on
the
availability.
availability,
Yeah.
ma'am, it's
Okay.
availability.
Then it's fine. That's fine. Thanks.
So thank you so much. We come to our next question. 23-year-old gestation, 27-year-old primary gravida. She comes to us with binders faces, normal intracranial anatomy, no cleft lip palate, no limb abnormalities, normal amniotic fluid, no maternal history of diabetes, lupus, or infection was reported. She denies any medication. There's no family history of craniofacial abnormalities, and the radiologist has mentioned it as binder like faces, that is maxillonasil dysplasia. Now, Dr. Seema, what would be the most appropriate genetic test would you want to test? And if, then which is the most appropriate genetic test?
Yeah, so you have rightly asked genetic test only. So whenever there is a binder phenotype, this can be, the non-genetic as well. Like we discussed last time also that this could be related to the maternal connective tissue disorders as well. So the most appropriate genetic test, the selection that will depend, of course, on the previous available testing. And usually, even if those tests are done like the routine first test I would like karyotype or the QFP and microarray, and subsequently the whole exome sequencing. So I would go step by step if my time permits. Otherwise, all together can be done. And WES, I would always prefer as a trio testing.
Right. So, so if the okay, so you actually already answered it. If it's isolated with normal CMA, normal growth, so what should the parents be told? Do we still go ahead with whole exome?
So this question was intended for Dr.
Yeah, sorry.
Ashwin
Yeah, I'm
Dalal.
sorry.
Yes.
This is, yeah. Dr. Ashwin Dalal, if you could take on this question. When binder's phenotype is isolated with normal CMA and growth, what should the parents be told?
Yeah, so any isolated anomaly in absence of the amniotic fluid being less and all, then we don't really attribute it to underlying. We have done a CMA. Whether to go for exome is really debatable because we want to do everything. We want to find a cause for everything. But in absence of growth being affected and a CMA being normal, it is very likely that it's not going to be a very serious condition and the prognosis is likely to be favorable. So I think it's better to follow up rather than doing too much investigation in such cases. Because any serious condition would affect growth or any other anomalies would be there or something like that.
Thank you. Thank you, Dr. Ashwin.
So our next question is to Dr. Gambhir sir. So you are counseling a couple whose NIPT and confirmatory amniocentesis revealed Turner syndrome in the fetus. Now, what should your approach to primary counseling be? Turner syndrome being like a phenotype which is non-lethal and maybe pro-life. Gambhir sir?
Right.
Are you
So,
there, sir? Yeah.
yeah, first of all, I would like to ensure that the ultrasound is totally normal in this case, because Turner's can sometimes show a lot of features in prenatal stages also, and that can give us a clue regarding the further clinical features that may appear in later life. So that is one thing. Second thing is that, like, let us again look at all the choices that are there. So emphasize that Turner syndrome is uniformly lethal. Never so. So it has got a variable spectrum, and many of them have got a good intelligence, and they can have a normal life. And now with the new medical care that is coming up, they can have full female life also. Then that is what is the second choice. So couple that via Turner syndrome is always mild. So it's not always mild. It has got certain clinical features that can have some conditions also, so that will require some special treatment and all that. But still, it is usually compatible with a prolonged life. So that means a good life quality also many times. So that is what I will answer. Then, so what were the other two questions? Can you go back one slide, please?
Lastly, yeah.
Yeah, focus on the recurrence risk and skip the phenotype discussion. I will definitely skip that and explain the broad clinical spectrum from lethal fetal hydrops. So that's what I suggest, said in the previous choice. I discussed that also. So that is all that will be discussed during the counseling approach to this particular pregnancy.
Right. Thank you, Dr. Gambhir. So I think now we have 2 minutes and we have two questions. So we just need one answer, one single answer. Dr. Shagun, an isolated unilateral talipus is detected at 20 weeks, which is the most appropriate counseling message.
I mean, here B is of course the best answer at this point, but still, I mean, even for an again isolated unilateral talipes, frankly, I would like to discuss with couple the possibility of still it being, a part of a chromosomal abnormality. Again, there has been some association shown with, especially sex chromosomal aneuploidies, but again, that's another discussion about whether we should be even looking for those. But the main important point, for which I always counsel my couples is that, this could be the first sign of an evolving condition, which could be, end up with subsequent, as we repeat scans, with other joints being involved and other contractures, and eventually turning out to be a neuromuscular disorder. So, in fact, now exome sequencing recent, reviews, and we had recently reviewed the data for our guidelines that has shown that even with isolated talipes, there's a 4% yield of exome sequencing for various neuromuscular conditions which are all monogenic. So actually, I always discuss all these options with my patient. Of course, reassurance, but and consultation with an orthopedics also, but along with an offer of testing if they wish to do so, and follow-up scans on 4-weekly intervals to look for other joints.
Thank you.
Thank you,
And-
ma'am. Our next question would be, in a fetus with borderline ventriculomegaly and normal anatomy and a normal CMA, should we emphasize on genetic, like what should the genetic counseling emphasize? So this question goes to Dr. Seema Thakur, ma'am.
Yeah, so this is a very common scenario when the ventriculomegaly is mild, and we have already done amniocentesis for microarray. And of course, simultaneously, we do for the CMV infection as well. And when everything comes out to be normal and there is no abnormalities in growth or amniotic fluid, then generally it is reported that the neurocognitive outcome is normal if all these reports are normal. So that's what we reassure the couple that it is going to be fine as far as the neurocognitive outcomes are concerned.
Right.
Okay. That brings to the last question, Rima, ma'am.
Yeah. So this is very quickly, we want an answer. 29-year-old primary gravida was referred at 26 weeks after fetal echocardiography showed dilated cardiomyopathy with reduced ventricular contractility, no structural heart defects, normal amniotic fluid and growth parameters. There was no maternal infection, no diabetes or medication exposure. Family history revealed that father's younger brother died at 12 years of age due to an enlarged heart of unclear cause. Genetic evaluation, whole exome of the fetus identified a heterozygous pathogenic variant in MYH7 gene associated with autosomal dominant familial cardiomyopathy. Segregation testing confirmed that the father carries the same pathogenic variant and is clinically asymptomatic, but shows mild left ventricular hypertrophy on echocardiography. So now with this background, our question is, Dr. Ashwin, how should we counsel this couple regarding the genetic finding and the implications for future pregnancies?
So, with the clinical features, it does look like autosomal dominant condition. So, for the answer, the B would be the kind of answer with the clinical features in the father and the father's brother being present. But cardiomyopathy is always a difficult case to counsel because of its variable expression patterns, and many times it is difficult then to counsel because many of these cardiomyopathies may manifest quite late in age, and then whether to terminate for such conditions also becomes difficult. So we need to keep in mind each of the types of cardiomyopathies and the mutation identified and take appropriate action in each case. I think.
And also variable expressivity is quite common. So, we can't predict.
Yeah, that's right.
Right. Thank you so much. I think we've crossed our time limits, but we didn't want to let go of all these wonderful panelists we have today. So I think we can end the session. We have a lot of questions waiting for us, so we could take them on. I would thank our wonderful panelists for those crisp answers. And I think there were a lot of take-home messages. Dr. Khurana, we would request you to kindly take on the question answer sessions.
Thank you, and thank you for one of the most brilliant webinars that we've had on genetics in recent times, and we've covered a huge amount of ground today, especially because we had such a brilliant set of panelists, and I would request them to stay on. We don't have that many questions because a lot of them got answered truly while we were going on. But the first question that comes along is from Rupali Bansal, who wants to know how many weeks is it legally allowed to do a fetal reduction by potassium chloride or microwave or radio frequency ablation. And so if we could have an answer to that question, Dr. Vandana Bansal, please.
Sir, by the new MTP Act, if the board allows, we can do termination, as you said, even in labor also. So any week can do, but if it is without the medical board, till 24 weeks.
Absolutely correct. That is what the rules very clearly say. And that takes us to our next question. And this is from Upasana Mukherjee, who wants to know, can we mention about the special permission for late termination in this case of Silver Russell? And Dr. Ratnapuri, please.
So we'll have to go into this in literature. This is associated with delay and intellectual disability. And you can approach your board if the patient and the family is willing. Let me tell you that it doesn't matter how severe the phenotype is. When we break the news to the family and the couple, really the couple, they do want to absorb it. They do want a little time to understand what they want to do. The answer is never an outright, I want to terminate it. At least I have not experienced that. And so with the time ticking away, it is ticking away, but by the law, you can approach the board. You can tell the family to approach the board. You as a doctor don't approach the board. The family is referred to the board.
Thank you. There is a very important question next, which is that this is from Rupali Bansal, that the only finding is a hypoplastic nasal bone, and of course no structural abnormalities. And we haven't mentioned gestational age, but let's presume it was 21 weeks. Should we send for all three tests, which is QFPCR, CMA, and a whole exome, or sequentially? So if Dr. Shagun Agarwal can take this question, please.
So, sir, I mean, in just an isolated hypoplastic nasal bone, usually I don't expect any yield in an exome, actually. So, my only concern remains here for Down syndrome and also for certain copy number variants. So, there are some largest studies actually, but I think two of them, they are from China. So, we have to take with a pinch of salt. But still, there is data which is showing that around 5% is Downs and 5% is other copy number variants, even if it's an isolated hypoplastic nasal bone. Because there is also some school of thought saying that an NIPT is enough. But an NIPT won't be enough because that would probably flag your Downs but would not pick up the CNVs. So for me, the right answer is a QFPCR and a chromosomal microarray. And here we could actually even do a low resolution chromosomal microarray because again the association is mainly with Downs and some of the commoner CNVs. So we are not really looking at the rarer, smaller CNVs which a high resolution array picks up.
Thank you. At which point I need a very, very important input from Dr. Ratnapuri. We have recent publications, single publications on single findings, such as a nasal bone, such as a unilateral clubfoot, such as a choroid plexus cyst. And most of these have an origin in China. And the question is that they seem to talk about an incremental yield when we do exome sequencing. How soon should we incorporate these into our counseling, and how soon should we incorporate these into our practice?
So how I think about this is when we want to find a publication for anything, you can always find it in literature. But what I follow is that if we have a series, if you have a cohort, and if it's from China, because a lot of exome sequencing data comes out from China, I do go back and look at which journal it's published in. Sometimes they give who has reviewed it, and all those things are actually very important into making a decision on how do we take testing forward. Remember that if we do testing, there is always a baseline risk of 2 to 3%, where anything could come out. It may or may not be related to the phenotype for which you did testing. But there would be a 97 and a 98%, which would be normal. So I think it's important to think of it as a whole.
Excellent. So therefore, again, the need for very, very professional genetic counseling in this particular situation. And we must be very open on our reading. Thank you so much for that. We've already discussed one of the questions on ventriculomegaly in detail. So we move on to the next question, which is from Dr. Manohar Sivasamy, where he says they had a fetus with echogenic kidneys for which a whole exome sequence was done. And the report came back as LAMP2 mutation, which has an association with nephrotic syndrome, Pearson syndrome, but was reported as uncertain significance, even though there was a phenotype-genotype correlation. And the pregnancy was continued, the baby succumbed after birth. How do we handle this situation? So, Dr. Seema Thakur, if you could give us an insight into this.
Yeah, so fetal echogenic kidneys, they can be related to multiple causes, and one of them is the commonest is the autosomal dominant kidneys and the autosomal recessive polycystic kidney. Recently, we are also coming across some metabolic disorders like so, and also for the ACE, the acid angiotensin converting enzyme. So there are lots of genes which are coming up as the echogenic kidneys. We recently published also our paper into this, but of course we didn't come across this gene. But here there is a catch that this particular variant that needs to be segregated in the parents, whether it is a biallelic inheritance, and also if the child has succumbed, then there should be some features like related to that, whether the kidney biopsy was done. So some findings which will be explaining us the genotype, so that we can correlate it clinically, so that we are in a better position in the next pregnancy. That suppose this, because it seems that this is an autosomal recessive condition, so there will be again a 25% recurrence risk. So before we give them any definite answer, we need to do certain postmortem studies, certain parental segregation studies, so that we can give them definite answers. So all these workup is needed. So it is not just that there is one report VUS and we can act into the next pregnancy and do the CVS and tell them that again whether the baby is okay or not.
Thank you. And that brings us to our next question on whether SMA carrier screening should be done in all pregnancies and for all those who are considering pregnancies. We've had a wonderful introduction to carrier screening in the past 2 years. So Professor Ratnapuri has spearheaded that movement for carrier screening. The role of routine SMA carrier screening before and during a pregnancy.
So we do know from multiple studies in India from different parts of the country that the carrier rate is on an average of about 1 in 40. So the chance that two partners who are not related, can be carriers and have a 25% risk of disease. But even though we keep everything, the chance of a baby being born, if we calculate, is on an average, I think about 1 in 7,000. But we do understand that the carrier rate is as common as it is for beta thalassemia, and so therefore the Society for Indian Academy of Medical Genetics, in collaboration with SFM and FOXY, recommend that these two conditions should be considered for universal carrier screening.
Yes, it is quite common. Every year one case will come back to us that you did the amniocentesis, but my baby has SMA. So probably it's the time that we should incorporate this similarly the way we did for beta thalassemia, because there are a couple coming back to us. Even we did the invasive testing for some other reason, and then the SMA was detected later on, and thankfully they are all the one the neonatal onset, so there is not much of the agony to the family. But yes, we need to learn this lesson, that this is getting commonly noticed, because now we are not getting thalassemia, we are not getting Down syndrome. So the next step is probably looking at the SMA, and it has to be accepted by the other clinicians as well, because many a times I write this down and then probably they are not being done. So we need to know that this is definitely does exist. I have started doing add-on on amniocentesis, and out of 10 12 only, I have got 2 carrier fetuses. So that means that it is not that uncommon. I don't mean to say that 2 per per 10 cases, that is the it is like that. But yes, the carrier status is high in our country, and so we need to look up at a in a bigger, in a more sensitive way. So
Excellent. So really the screening has to be geographically changed, and as soon as
universal,
possible, the
yeah,
better it is. Yes.
yeah. We all should be talking about this.
Yes, and especially communities that seem to have a higher incidence, like the Kashmiris have such a high incidence of SMA, that we really need to encourage them to have routine carrier screening in that part of the country. Now, there is a very specific question, and this is that there is a couple where we have seen where Dr. Tulika Joshi has done an amnio for multiple soft markers, and the microarray was normal, but there was an LCSH37MB abnormality on chromosomal 14. Is it significant? And how to proceed? So, Dr. Sunita Bijarnia, please. Is Sunita still with us? No, I
I
don't
think she's
see her.
left, sir.
Yeah. Yes.
But is it
So, any?
okay if I answer it?
Yes,
Because
of course.
I have a
Certainly, Shagun.
case, I mean,
Yeah.
a same
Yeah.
similar case, so that's why.
Yeah.
So
Yeah.
basically, I think what she means is a long stretch of homozygosity, 37 MB on this chromosome. So these kind of, we often see these reports in microarray when there is no CNB, but we get these stretches of homozygosity. So again, in most cases, especially when you have consanguineous couple and shorter stretches of homozygosity, shorter being means less than 5 MB typically, they don't, I mean, usually don't mean much most of the times. Of course, the possibility still remains that the couple may be carrier of some autosomal recessive condition, and that is in that region, but is a that's something we can't really look at. So the only thing what happens, I mean, when you have a single chromosome and we have a large stretch of homozygosity as we are seeing here, so then in that case, there is a possibility that this is a uniparental disomy of that particular region on that chromosome. So then in this particular point, then the next step is to look whether it is an imprinted region. So if it is not an imprinted region, then again, this is unlikely to cause anything. If it is an imprinted region, then the fetus may develop an imprinting disorder related to that particular region of the chromosome. So in fact, chromosome 14 is known to be an imprinted chromosome, at least in certain parts. So in fact, I mean, again, we'll have to see. She's not given those details, which region is involved exactly. The whole chromosome is not imprinted. But there are two diseases which are known to be associated with a particular region of chromosome 14 due to UPD. So they are if there is a maternal UPD, then it's called as Temple syndrome, and if it's a paternal UPD of the same region, then there is a different condition. I'm forgetting the name. It's a complicated name. So both of them do present with a fetal phenotype. So in fact, the case I had just had a hypoplastic nasal bone, and that baby did have similar finding on an array where it was a uniparental disomy of chromosome 14, and then the baby was actually did evolve on to having the other findings of the condition, which is Temple syndrome, and the finding there is FGR basically. So initially presented with hypoplastic nasal bone, array showed this UPD 14, and then when we called her for a repeat scan, the baby did have IUGR, which is a feature of maternal UPD 14. So basically, again, I don't know what the region here is, but larger main message is that larger stretches of homozygosity involving only a single chromosome, we need to again look whether it's an imprinted chromosome, and then from there on, the counseling and the further decisions would be taken.
Thank you. We move on to the next question, which is really, I was hoping somebody would ask this question, and that is to set the ball rolling. This is from Jay Lakhani. When do we advise a clinical exome sequencing? When do we ask for a whole exome sequencing? What is a rapid exome sequencing? What is trio exome sequencing? And what is this so-called new big data sequencing? And let's start with inputs from just about everybody. And Dr. Sitapal, could you get this rolling for us? How do you use these recipes in your daily kitchen?
Well, if it's an isolated anomaly, then I would, and looking at chromosomal problems, I would rather go for a CMA. But if it's a multitude of anomalies and we're looking at a syndromic association, then the recommendation obviously is to go for an exome, which is trioexome, and not restrict to a single exome, as Madam had said earlier. And I think clinical exome, it depends if you like keeping, though it is whole exome is better, but if you have a typical sort of a rasopathy or looking at specific set of a panel set of a, maybe you can offer that, but now the recommendation is to offer whole exome rather than clinical, if I'm correct there.
Well, let's get the inputs of the others and see what they have to say. So, Dr. Deepanjana, when this comes to you as a question from a practicing doctor, what is your answer?
So these are basically terms which are more or less used by the company people so that we can understand what we want. What to test should, as like all my senior madams and sirs over here would always say, that what to test would depend on what differentials I am getting, what disease I am thinking of, what syndromes I am thinking of. I don't think we can classify, we can give a straight answer for this. But clinical exome is where we are looking at specific 6,000 genes, which are clinically significant. This was first launched because the prices were too high for whole exome. In whole exome, we are looking at only the exonic. So exome means the genes are divided into coding regions, which we call like the exon, and there are non-coding regions in between these regions, which we call as the intron. So when we are looking at exome, so clinical exome would mean 6,000 genes where the coding regions are, those coding regions of those 6,000 genes. And whole exome would mean that there are 22,000 genes, so the coding regions of those 22,000 genes. And when we say trio, it normally would mean the parents and the index child, or the parents and the fetus. And whole genome or big data would mean that as I said, that the genome, only a part of it is the genes, that it's only a very minuscule part. There are a lot of other satellites, there is the intronic regions, there are many other repeat regions. So the entire thing, if we sequence, is what we call as the whole genome. So that would be my answer.
Thank you. We get one or two more opinions, and we then conclude this particular aspect of the discussion. The industry now promises us the world with the deep exome, or the classical names for this is exome first, Orion first, exome plus, etc., where we get much more data, and we are now being told that we don't need to really carry out a microarray. And so everybody is confused, and everybody new in the field is confused. Everybody who had their stuff out there worked out is confused. And then someone comes and tells us that actually the whole story between clinical exome and the whole exome was actually a trade war between the Affymetrix people and the Lumina platform. So we can't really separate ourselves from the politics of commerce. But how do we handle this? And I want somebody from industry to get the ball rolling. Shaiket, are you still with us? Shaiket, could you unmute yourself if you're still with us? Because then I know, has some inputs on this product because they do it. Alternatively, if we have Dr. Prakash Gambhir, how does LifeCell handle this?
Hi, Dr. Rana. Sorry, I'm still here.
Shakir, thank you for being there. So could you tell me this whole story about the politics of commerce and exome sequencing as far as the companies are concerned, and the additional data you keep promising us and no microarray required?
Yeah, it's a good question, pretty controversial. So
Yes, that's why
whole
we're here
exome
today.
So when you look at the whole exome, clinical exome, if Dipanjana said, I think there is no politics of commerce per se. When you look at clinical exome, we are looking at OMIM morbid genes mostly, where these genes are well connected with the disorders. There is a genotype, genotype phenotype correlations are pretty straightforward. But when we look at a whole exome per se, we are looking at more than OMIM morbid genes. But and then clinical exome would be around 5,000, 6,000 genes. Every company has their own standardized panel for clinical exome. Whereas whole exome, it goes down to more than 20,000 plus genes. But when it comes to data and can exome replace microarray, well, that's a very tricky question because it depends on a lot of validations, what kind of validation each lab has done. The reason why most labs generate more data is because we see the copy number variation calls has better sensitivity when you generate high data. But it's not only data that matters when it comes of copy number variation calls. It meant a lot of things comes into play, whether how much validation has been done, what's your pipeline, what kind of pipeline you're using, what kind of uh, multiple variant steps that you're taking out. So microarray can be replaced, not per se. A lot of things microarray can pick up still cannot be picked up by exome sequencing. I think Ratnam is here, UPDs, LOH are still something that can never be picked up by exome sequencing. Larger deletion duplication, yes, probably the validations by the labs are good. And in large deletion duplication, more than 500 kb, it can be picked up. But till the guidelines and recommendations are not there, we would still say we have to depend on how good the validation has been done by the lab. But only data is not the only data is not the reason why copy number variation calls will be better. A lot of other factor comes into play.
Thank you for that. And so the final word on these various steps by Dr. Ratnapuri, please, as far as exome sequencing is concerned.
I think it again stems from what is your differential diagnosis. If it's an ecogenic bowel, you're looking for cystic fibrosis, it's fine to do a clinical exome. It's smaller data, the depth is more. You can even look for the deletion duplications. If it's non-specific, you're looking at many things, it's fine to do a whole exome. But I think in fetuses, we are not doing research on the clinical aspect. We are looking at omomorbid genes, so it's fine to do a clinical exome.
Wonderful.
I think
Thank
it
you.
just has to be a conversation with the lab that you're sending the sample to.
Completely. So the question then comes, Dr. Dipanjana, could you please tell us this conversation between the practitioner who puts the needle in and the lab should be mediated by somebody who is a genetic counselor, or should a genetic counselor on behalf of the lab handle this information, or should our salesperson handle it?
So, fortunately or unfortunately, we don't have too many geneticists or genetic counselors around, and the number of people are very less. So, most of the labs, they have gone ahead and hired genetic counselor to speak. But if I follow what the US UK model is, lab genetic counselors are completely separate from what the field genetic counselor or the genetic counselor sitting in the clinics, because there's a basic conflict of interests over there. And a genetic counselor is supposed to be completely neutral and looking in the perspective of the patient and the problem at hand. And that coming from the lab sometimes, though I know my friends are there, many of them are very neutral, but still it's a job they have with the associated labs. So yes, there needs to be somebody who mediates it. Normally in the Western world, it is the genetic counselor. The clinical geneticist will probably speak to the parents, do the differentials, help in sorting these things out. The genetic counselor will further counsel the parents, the family, and also help in coordination of the entire thing. But in India, if I look at numbers, genetic counselors are only 150. So it's impossible, to segregate between lab and clinics that way.
Thank you, which really settles that question completely.
Also,
yes.
just to add one thing here, I think one important fact, probably from a genetic counseling perspective, is the counselor should also know the limitation of each test,
Yes.
which is very important, right? Not all exome positive are 100% positive, and not all exome negative. As ma'am said, the collective diagnostic yield of all the tests is very low. So I mean, it's very important to know what is the limitation of each test in methodology. That is a very important point in counseling.
Great input, Shaikhat. Very nice. Thank you. We have two questions that have already been answered on echogenic bowel and on trisomy 16. So we move on to this very important question that everybody seems to ask. If a patient has a previous child with Downs and they want 100% confirmation in the second pregnancy, what test should be done? Dr. Vandana Bansal, how do you handle this question? They want 100%.
So if patient has a previous child with Downs and they want 100, then it has to be an amniocentesis to be done. First, so we will have to see whether the previous child karyotype has been done or not. Both ways, we will counsel them on the chances, non-disjunction, translocations. And if they want 100%, yes, I will go ahead and do an amniocentesis, even if our structural scan is completely normal.
Excellent. And then there is a question from Dr. Singh. Should we routinely offer prenatal invasive testing for isolated echogenic bowel at the time of the targeted anomaly scan if we had already found a combined first trimester screen shows a low risk? And of course, the answer is yes. We've answered that as we've gone along. And then the question is, can we offer termination of pregnancy on the basis of a FISH report only showing trisomy 21, or do we need a karyotype report before offering a termination of pregnancy? So, Dr. Vamshi, what is your hospital policy on this, your lab policy on this? Is Dr. Vamshi still with us? Otherwise, a final lid on this by Dr. Ratnapuri, please. Should we wait for a karyotype, or can we terminate on the basis of a FISH report for trisomy 21?
No, you can terminate on the basis of a FISH report.
Wonderful. So this is simple. And Dr. Singh also has another question that there is an isolated unilateral clubfoot, and in the presence of a low risk in the first trimester screen, do we do invasive testing? And I think we answered that question a few minutes ago. Then there is an isolated pericardial effusion. The torch evaluation has been normal, if we can call it that. A low risk NIPT, what next? A microarray or a whole exome sequencing? This is from Asawari Deshmukh. Do we still have Dr. Ashwin here? Dr. Ashwin Dalal, are you still with us? I know we've run over time and some of us have had to leave for family commitments. Otherwise, if we can have anybody on the panel answer this question. Isolated pericardial effusion, background torch, okay, background and NIPT low risk, what next, CMA or whole exome?
Bandhana, what would you do here? I think just follow up a little, look at chromosomes.
Yes, madam, but I think this pericardial effusion, I look for all other causes for non-immune kind of, look at the heart, look at ascites, everything.
I mean, that's what I meant by follow up, that
Yes.
I presume that in this scan it's isolated. So then you do a follow up scan to see how it's evolving, no?
Yes. And this torch and normal NIPT is not giving me much assurance. It is, we are seeing some pathology, we need to act on it. So probably if this pericardial effusion is significant, then I might do an amniocentesis. maybe if I
Excellent. Yes.
I would also want to do an amnio and probably an exome here, because hoping that, an exome would also, of course, now look at the chromosomes and CNV to some extent. And then I would like to, kind of, as Dr. Vanda ma'am is mentioning, that this could be sometimes a sign of an evolving hydrops. Maybe this is the first sign which has come up at this gestation. And many of the hydrops, especially in our setting, are actually, are due to single gene disorders, a lot of them LSDs, lysosomal storage disorders. I would like to do an exome actually here, a QFPCR and an exome.
Can I just say that we have to see what is the extent of the pericardial
Yes, ma'am.
effusion,
Yes, of
what is the
course.
gestation?
significant.
Yes, ma'am.
I
Of
think
course,
all
ma'am.
that is important
But
before we
here
put
again,
in the
madam, do
needles.
we do a trio then now? The problem is this with
And
our
if you do an exome, you have to do a trio, isn't it? That's the thing.
microarray also.
Ideally.
Well, again, I guess that depends on the indication for doing the exome, like we've heard. And therefore, the essence of having today's meeting, and that was genetic counseling, is such an important component. It's something that we can incorporate by becoming interdisciplinary, that you and me will have to learn a lot about other fields, but also that our current status of knowledge is so explosive on a daily basis that we really need to involve genetic counselors. But importantly, we need a training program where we really, really need to create. And I think we'll get together between the genetic societies and Society of Fetal Medicine and come up with possibly additional training programs, because we can't have somebody coming up for the sake of PNDT and having a degree from Karnal Veterinary College and then expect them to perform the same way as qualified genetic counselors. We have to do something urgently about that. So I hope this serves as a stepping stone. And thank you, each one of you, for being with us tonight. Thank you especially to Dr. Ratnapuri for leading our genetics arm at the Society of Fetal Medicine. And thank you, everybody else, for being here tonight. Our genetics people are completely indispensable for maintaining our Journal of Fetal Medicine as well. A special thank you to all of you for supporting our Journal of Fetal Medicine. Thank you, industry, for being a part of this. We all learn from each other, we depend on each other, and we do understand that programs like this will bring us together. We do hope you continue to support our teaching programs as well. Thank you, the attendees, for being here tonight. And thank you, Rima, for putting this together as always with such aplomb. Thank you, Dipanjana, for originating this idea and for giving us the moderation for this. Thank you, each one of you, and good night.
Good night. Thank you, Doctor.
Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you for the opportunity. Thank you.